Shalu, they'll just try and check their sharing and all, and after that, getting confirmed, you can start with the the CV of the chairpersons and all. Okay.
Okay, ma'am. Ma'am,
Are you seeing?
we'll start sharp at 10 o'clock.
Are you
9 o'clock.
seeing my
9.
screen?
Yeah, yeah.
Yeah.
We are starting at 9 o'clock, right?
Yeah.
Yeah.
Yeah. So can I just minimize and stop this sharing?
Yeah.
Yes.
Stop sharing, right? I will stop sharing. So is it off now?
Yes.
Yes. Okay. Great. Thank you. Thank you so much.
One more team has to join.
Right.
I think Mayuri has to join.
My video is not on, so it will remain off only like that.
No. At 9 o'clock they'll start the videos.
Okay. Fine. Great. Thank you so much.
Okay. Your trainee has joined?
Yeah, we are together only, so we have one PPT only. So we thought that we won't waste time that way.
No problem. And
how much time? Like you said, 20 minutes total for us, both of us.
Yeah. 3 teams are there, so total 20 minutes for each team.
Yeah. So your time is after our time ends, right?
Yeah. No. That is around 15 minutes for you, and then 5 minutes for the discussion.
Okay.
Yeah.
Okay. Fine.
That can vary, but we have to stop by at 20 minutes because 3 presentations in 1 hour, right? So that's
okay.
All. Okay.
Fine.
Good morning, Tashni. You have joined?
Yes.
Are you okay?
Yeah, okay.
Okay, we'll start at 9 o'clock. What we can do is actually, I'll start introducing the moderators. I'll introduce you, and after that, you can introduce the mentors and the trainees. Okay.
Okay.
Okay. After that, the first batch team can start. Anuja's team can start. Okay.
Okay.
Hi everyone. Hello.
Hello,
Hi.
sir. Good morning, sir.
Hello, good morning.
Nice to see that people have come in 5 minutes early. Great.
Sir, we have three teams here, and the first team is TMH.
Yeah.
And first we'll introduce the mentors and the trainees, and the first team will start, and they have to finish their presentation by around 15 minutes, and discussion for the next 5 minutes, and the next 20 minutes, the next team, like that it will go. So we'll try to finish by 1 hour time.
Perfect.
Yeah.
Ma'am, we will put 5 minutes timer on the screen, ma'am, when the discussion starts.
Okay. Shalu, you can put that timer at the beginning of the presentation itself, so that they'll also know when to finish it, their presentation. Kashneen, after the first team's presentation stops, maybe you can start the discussion for them.
Okay.
Okay,
Doctor.
Yeah. I can start now because we don't want to waste much time. Only strict 1 hour is with us. So maybe we'll take 1 hour for our introduction. Good morning, everyone. All the panelists, all the trainees and the mentors, and all the delegates who are watching this program. A warm welcome to the final day and the third day of our Fhno 2021 academic program. And hope you all had a good academic feast yesterday and day before. Um, Today's session in Hall C is a trainee session. This is a critical review of recent literature impacting on head and neck oncology practice. So we have 3 teams with us. I am Dr. Elizabeth Matthew, a head and neck surgeon from Regional Cancer Center, Thiruvananthapuram, the host institute. And my moderator with me is Dr. Tashneen. She is the head of the head and neck surgery and ENT department in the Barua Cancer Institute in Assam. Over to you, Dr. Tashneen, for introducing the first team.
A very good morning, everyone, to the third day of the Fhno 2021. Now, introducing the first trainee is Dr. Nityananda Chidambaranathan from TMH Mumbai, and the mentor is Dr. Anuja Desmukh, who is professor of the Department of Surgical Oncology, Head and Neck Services, TMH Mumbai. And their topic is evaluation of overall survival in patients with anaplastic thyroid carcinoma, which has come out in the journal JAMA Oncology in 2020. I'd like to request Dr. Nityananda Chidambaranathan to proceed with his presentation.
It is in your name, madam. So. Are you able to see my presentation?
Yes.
Good morning, everyone. So today I'll be critically reviewing a paper recently published in JAMA Oncology and Head Neck Oncology, impacting the head neck oncology practice. So I am Dr. Nityanand, trainee in Head Neck Oncology in Tata Memorial Hospital. And my mentor will be Dr. Anuja Desmukh, Professor of Head Neck Oncology, Tata Memorial Hospital.
I'm not able to.
So this is a paper we are going to discuss about. It was published in JAMA Oncology 2020, evaluation of overall survival in the patients with anaplastic thyroid cancer over the period of 20 years. This was MD Anderson Cancer Center's experience. As we all know, the anaplastic thyroid cancer is a very aggressive tumor with an overall median survival of just 3 months. And most of these patients present at advanced stages, and they have a present with distant metastasis also. This was the median overall survival recently published in SIA database, showing just at the 3.16 months as a median overall survival. And the disease-specific mortality of this anaplastic carcinoma leads on to about 99%, and more than 50% of the anaplastic thyroid cancer are the causes of the cancer-related mortality in thyroid cancer patients. So the timeline and management of anaplastic thyroid cancers in MD Anderson Cancer Center, actually they have 2 landmark periods. One is in 2014 and 2017. In 2014, they have introduced a protocol named as a FAST protocol that is facilitating anaplastic thyroid cancer systematic management. And in 2017, they integrated the surgery, neoadjuvant chemotherapy, and adjuvant RT in their management. So what is FAST protocol? This is nothing but fast tracking the early diagnosis and early initiation of the treatment for anaplastic thyroid cancer, and not much of delay is there in diagnosing and then starting the treatment immediately. So this MD Anderson Cancer Center is one of the cancer referral center where most of the anaplastic thyroid cancers are referred there, and so that they will start the molecular testing and initial diagnosis treatment fast, and the treatment also is started early. So with the improved understanding and the testing of the tumor genetics, there was increased enrollment in clinical trials, and more number of patients were actually tested for BRAF mutation and other molecular testing, and based on which the targeted therapy was started. These are the initial case series, which is actually a small retrospective series showing the neoadjuvant chemotherapy of BRAF targeted therapies in anaplastic thyroid cancer, and how they increased the response, and they went into surgery after the BRAF targeted therapy. With this background in mind, the question in their mind was: is emerging use of targeted therapy, immunotherapy, and surgery and radiation associated with the improved overall survival in patients with anaplastic thyroid cancer? So their hypothesis was there was a significant improvement in overall survival in the last 2 decades, especially in the last 5 years. So the methods is they were retrospectively collected about 479 patients who were treated in MD Anderson Cancer Center from 2000 to 2019, and they divide into 3 cohorts. That is before the initiation of FAST protocol, that is 2000 to 2013 period, and 2014 to 2016 period, that is after the initiation of the FAST protocol, and 2017 to 2019, that is integration of NACT followed by surgery followed by adjuvant therapy. So this was the FAST protocol they used, and this was the treatment protocol. Mostly for stage 4A was directly upfront operable, and stage 4B, if they're operable, they go for surgery, and if they're inoperable, they do molecular testing and they give NACT. If they're resectable, they go in for surgery. If unresectable, they treat it with other methods. So they use Kaplan-Meier curves for survival analysis and log-rank test to compare the overall survival. So coming to the results, as you can see, there is a steady increase in this bar diagram shows a steady increase in the number of anaplastic thyroid cancer incidents in MD Anderson Cancer Center over this period. As this is the tertiary care referral center, more of the patients with anaplastic thyroid cancer used to be referred here. So this is why there is an increase in ATC in recent years. And there were 51% of men with a median age of 65 years. Most importantly, what to be noted is more patients, almost 53% of patients presented with stage 4C, and 36% were presented with in stage 4B. Over the years also, the rates of BRAF testing have actually increased. The overall testing for the entire cohort was 56%, but as you can see from 2000 to 2019, there was steady increase in the BRAF testing, just almost 97% in the last 2 years, 2017 to 19. And the positivity rate remains stable throughout the years, and the overall positivity for the entire cohort is 38%. So they use various modality of treatment. So what is important in this table is the use of the targeted therapy and the immunotherapy improved drastically over the recent years. And one last thing is about the use of neoadjuvant chemotherapy followed by surgery also. They've started in 2017, 2019. And one important other point is they had very low threshold in patients to enroll in clinical trials of this anaplastic thyroid cancers. So this is a very important table showing the drastic improvement in the overall survival. The estimated 2-year overall survival was 18%, and it's almost doubled over the period in 2017 to 19, and that translated into the median overall survival from 8 months to almost 16 months in this 2 years. So this is the Kaplan-Meier curve showing the same thing: 18% 2-year overall survival in 2000 to 2013, and 42% from 2017 to 19. Stage-wise overall survival also improved at 2 years also. But what we kept in mind is there were more patients actually in stage 4C. As I told you, there was 50% of the patients were more of stage 4C, and even in stage 4C, there was drastic improvement in overall survival. So then 2013 it was 9%, but in 2017 to 19 it was 37%. So in multivariate analysis, looking at multiple factors, the most important factors was patients who were treated between the years of 2017 to 19 and in stage 4C. These 2 factors were responsible for the better overall survival in the entire cohort. So use of targeted therapy also drastically improved over the years, and this Kaplan-Meier curves shows that the patients who received targeted therapy had statistically better overall survival than patients who did not receive targeted therapy. Similarly, immunotherapy also usage of immunotherapy also increased over the years. But as you can see in this table, the immunotherapy alone, that is per se, didn't have any overall survival when compared to immunotherapy along with targeted therapy. The use of BRAF targeted therapy along with surgery also increased over time. That is increased at after 2017 to 19, and they found it the patients who underwent surgery after the neoadjuvant chemotherapy had significant overall survival of 94% when compared to patients who did not undergo surgery. So coming to the discussion, this was a single large institutional cohort study with a significant overall survival improvement. And this increased ATC presentation is due to the referral bias due to the FAST program. The molecular testing has been increased over the years, and this testing has improved the use of targeted therapy, which has improved the overall survival. BRAF targeted therapy along with surgery showed drastic improvement in survival. So the implementation of FAST program and the decreased access time and increased ATC referral significantly with the 34% of participation in ATC treatment trials. So immunotherapy per se alone is not causing improvement in survival, but immunotherapy in combination with other targeted therapy definitely have improvement in survival. So we did a review of literature. These are the studies from various institutes, and most of this, if you can see, they have a case series about 50 to 100 patients, and the case series are from either Mayo Clinic, one from the Australian group, one is from the Portuguese group, one is from the Duke Cancer Institute, and one is from MSKCC. So what is important in this table is they compared, most of them compared the multimodal treatment in compared with the conventional old treatment, that is radiation, and definitely multimodal treatment has improved survival. So this was one of the large series about 104 patients from MSKCC group, and most of these patients in this treatment group received concurrent chemoradiotherapy, and 51% used trimodal treatment. So the chemotherapy regimen was doxorubicin and paclitaxel combination, and they have the same BRAF mutation rate as we found in our study, that is the MD Anderson Cancer Center, that is 38%. The important point to be noted is 1 year overall survival is 34%. In multivariate analysis, they found that patient who received radiation dose more than 60 grays, and a patient who received trimodality treatment, therapy had better overall survival. This was one of the initial case series where they used the BRAF targeted therapy as NACT followed by the surgery based on the response assessment. So they studied about 6 patients, and they found 1 year overall survival about 83%. What is the important point to be noted in this study was there was a decreased need for the tracheostomy, there was high pathological response rate, and there was a durable regional control with the symptom amelioration. So on follow-up of these patients, 2 patients only developed actually failed due to distant metastasis. Otherwise, there was no locoregional disease failure during their follow-up. This is in Indian scenario. That is this study from the HEPJ Lucknow. Actually, they studied about the molecular testing, and what the most common mutation they found was BRAF mutation in 29%, and second most common mutation was P53. So coming to the SWOT analysis, the strength of the studies is a single large institutional studies. It was studied over the 20-year period. So this study also described the BRAF mutation rates and what is the how the molecular testing has been increased over the years. And this molecular testing actually increased the drastic improvement in the survival. And they can use the targeted therapy as an oral administration and still achieve overall survival improvement. And so far, and that's how they devised a more personalized treatment towards the therapy. The weakness of the study is retrospective, and so it has a selection bias. And since it has a tertiary center, and so a referral bias they receive more of ATC as a referral cases, but they have not compared any other treatment modality like CTRT. Treatment option with wild type of BRAF mutation was not mentioned, and what are the treatment option of NACT non-responders was not mentioned, and the requirement of tracheostomy was not discussed in the study. The opportunities by this paper are this results in it encourages readers to adapt more of molecular testing in the routine practice, and how this molecular testing will achieve a better survival. And it also tells us to adopt the FAST protocol and involve a multidisciplinary treatment protocol for ATC. It encourages to enroll more of the ATC patient in clinical trial. The threats are that toxicity profiles were not discussed, and due to the cost and the availability, the limited global widespread use of this molecular testing and this targeted therapy. And they've not discussed about anything about this non-trial setting patients, patients with poor ECOG status or poor general condition. What are the other options available? And even though there is a recent interest in the immunotherapy, this study has shown that immunotherapy alone per se did not have any survival improvement when compared with the combination. So they have concluded by saying nearly twice the rate of overall shift of the median or overall survival and 300% survival increase compared to the recent SEER data. So era of untreatable ATC, which was initially all declared as palliative, has now changed into our mode of targeted and personalized therapy. And over this 5 years, this specialized treatment has increased the overall survival. So the take-home message by my presentation is anaplastic thyroid cancers, even though clinically aggressive, management is straight away not deemed palliative, and all ATC patients should be considered for molecular testing. BRAF mutation rates, it ranges up to 38%, and trimodality treatment can achieve maximum overall survival. So better to start with early initiation of treatment, and oncological treatment is depending on the molecular testing, that is the use of targeted therapy and immunotherapy. Thank you.
Thank you, Dr. Nityananda, for your nice presentation. Now I'd like to
Hello, this is Dr. Anuja here.
Yeah,
so
Professor
I have
Anuja.
1 minute presentation as a mentor
after
Dr. Nityanand.
Yes, Professor Anuja, you proceed.
So I will be talking on this paper and the lessons learned from this paper. So we know that anaplastic cancer is an intractable cancer. It's a rare cancer with a short tumor doubling time, low overall survival, and it is the deadliest solid cancer in human and difficult to have any randomized controlled trial. And it has got a unique molecular signature, and the BRAF mutation is the actionable mutation, which we know. The oncological treatment option for ATC are very poor because of various reasons, because of no standard treatment and the low response to the treatment. We know that we lost Kevin Towers with anaplastic thyroid cancer. He lived longer as compared to other patients. That's what doctor has anticipated. And he really fought hard, and he was an unbelievable competitor. This is the story of anaplastic thyroid cancer. But the traditional methods are not going to give us the answer for this intractable cancer. The basket study actually gives the look at the genomic alteration in the tumor and the drug acting on it. And it is concentrated in this study, and regardless where the cancer actually originates. And the effect of the drug that targets the same genomic alteration across a variety of tumor types is studied in the basket study. So we know that the two basket studies has actually changed the practice, breakthrough therapy, and FDA approval for the two drugs combination in the May 2018 for anaplastic thyroid cancer. And this is the various innovative therapies and the pathways leading to that. So the treatment algorithm in ATA 2021 has been changed because of this new paradigm shift in the treatment. And what we are doing is a rapid BRAF assessment and quickly treating this patient with the molecular markers targeted therapy. So the practice changing study, which is based on the molecular based personalized therapy, which has improved the overall survival in ATC and which has changed the recommendation in the latest ATA guidelines. Thank you so much. And I feel this study is really impacted on the head and neck oncology practice. Thank you.
Thank you, Professor Anuja. Now, I think Dr. Elizabeth, is there time for discussion?
Yeah, you can take 2 minutes.
2 minutes, okay. Now everything is clear that anaplastic is such a lethal, and it has the highest mortality amongst all the thyroid cancers we know. But this study, yet it claims that from 35% overall survival in 1 year, they have raised to 59% in the last year, I think, overall survival. Then how do you justify the ATA guidelines? Overall survival is 20% in 1 year. What is your comment, Professor Anuja, over that? This paper is showing that the overall survival in 1 year is increasing up to 59% in the last year.
So the thing is, you are not giving the traditional method which has been used for decade and decade by the oncological setup. And what we were doing, that we were using the routine kind of drugs, the
Yes.
chemotherapeutic drugs, the systemic therapy. However, these drugs were not helping because I think the anaplastic cancer has got a different kind of a mutational burden, and which we were not understanding. And if you look at this mutation type of this patient, the patient has got a loads of mutation which is actually uh, causing a aggressive nature uh, of this disease. And if you have targeting this, then what you are getting is the response which is more sustainable. And if you combine with the immunotherapy which is coming into the picture, irrespective of the mutation analysis, you can give a combination with the targeted therapy. And I think this is a real world data, and yet many more studies will be there, but it has changed a practice, and we know that it is in black and white in a print. So it is a real data about overall survival which has improved in a ATC, which is unbelievable. I can understand that.
Okay, thank you. And one more thing, in the Indian scenario, BREF V600E testing, is it feasible in an institute in all the cases of ATC? What do you?
So what they say, that you don't require a fancy kind of a NGS testing for checking the BRAF mutation for the patient. But what you require is a rapid BRAF by a ISC method. And if you have a good pathology colleagues, I think they will be able to do a rapid BRAF on a core biopsy specimen with a USG guided sample, and then you will get the report. And if the patient is BRAF positive, then you can start a dual synergistic kind of a drugs, which are oral tablets. They are not like injectable. So both the drugs are can be given oral. If the patient is not able to swallow, you can open the capsule and put it in the Ryle's tube. You can put it in the PEG tube. So it is
Anuja.
doable. Yeah.
Thank you very much. Thank you.
Yeah, thank you, Dr. Tashneem. Thank you, Anuja and Nityanand. Now we'll move on to the second one because we are short of time. Second presentation is a neck dissection based on sentinel lymph node navigation versus selective neck dissection in early oral cancer. The trainee is Dr. Dheeraj and mentor is Dr. Smriti Panda from AIMS. Over to you.
Good morning, ma'am. There is some technical issue. Can we request the third team to start? I think there is some, Dr. Smriti Panda has requested if the third team can start the presentation. There is some technical issue. Sorry for the delay.
Okay, then the third team is Dr. Divya, the trainee, and Dr. Mayuri. Over to you, Divya. Without wasting much time, you can start. Dr. Divya?
Yes, madam. Yes, madam.
Yeah.
Let me share my presentation.
Okay.
Yes, madam. Am I audible?
Yes, very much. You can start.
1 minute. Let me share my presentation, madam.
Divya is a trainee from Regional Cancer Center. She's an associate professor in ENT in Calicut Medical College. And Dr. Mayuri is from Aster Medicity, Kochi. Welcome, both of you.
Am my screen visible now?
Yes.
So, respected faculty, members of the profession, and dear friends, we all know the nodal status is the most important prognostic factor in patients with squamous cell carcinoma of the oral cavity. The presence of nodal metastasis, it decreases the survival in about 50%, and hence appropriate management of neck nodes is important to maximize loco-regional control and overall survival. But if the nodal metastasis is limited to a single node, administration of adjuvant treatment does not find universal acceptance. And as per the ASCO guidelines published in JCO in 2019, adjuvant neck radiotherapy should not be administered to a single pathologically positive node without extranodal extension, or there is any indications from the primary tumor like perineural invasion, lymphovascular space invasion, or it is T3 or T4. The strength of recommendation was moderate. Single positive node cannot be considered as a homogeneous entity. Why? Because the size of the deposit within the node, which is a more accurate depictor of disease burden, the extent of extranodal extension, and the topography of the single node is to be considered before patients with N1 neck are consigned to follow-up regime without adjuvant treatment. With this background, let me come to the study, The Determinants of Prognosis in Patients with Oral Squamous Cell Carcinoma Metastasizing to a Single Cervical Lymph Node by Arun Patatil, published in Oral Oncology Online 25 October 2021. This study focused on the N1 neck exclusively, and they looked into the prognostic clinical pathological factors and how those clinical pathological factors are guiding the use of adjuvant treatment. This was a retrospective study which included 707 patients who underwent surgery as the main modality of treatment during the time period April 2011 to December 2017. The study procedures in the depth of invasion was measured in millimeters. Lymphovascular invasion, perineural infiltration, and extranodal invasion were recorded as positive or negative, and the largest size of nodal deposit and the extent of extranodal extension were measured using optical micrometer in millimeter. AJCC 7th edition was used to stage the patient, and with the available retrospective data, the staging was done restaged to AJCC 8th edition. The survival analysis, the follow-up data was censored on 15th July 2020, and the last patient who was enrolled in the study had a follow-up period of 2.5 years. The date of surgery was the start date for all follow-up data. The Kaplan-Meier survival case was used to estimate the overall survival and the disease-free survival. The long-ranked statistic was used to compare the survival in prognostic subgroups, and multivariate proportional hazard model to assess the prognostic impact of demographic and tumor characteristic. Statistical significance was noted if the p-value was less than 0.05. Coming to the results of the study, there were 707 patients with a median follow-up of 35.2 months. Out of the 707 patients, 394 patients were not negative and 313 patients were node positive. Out of the 313 node positive patients, multiple node positive was seen in 192, whereas our focus of our study, that is a single positive node, was seen in 121 patients, and this group is termed as NS group. So single positive node is NS group. In the NS group, extranodal extension was seen in 30 patients, and the extent of extranodal extension could be measured in 29 patients. Single positive node was predominantly limited to level 1, that is 48%, and in level 2, it was 38%. When we looked into the nodal failure in the N0, it was 3.1% compared to 9.92% in the single node positive group, which was statistically significant. In the whole cohort, recurrences were recorded in 176 patients and deaths in 199 patients. To look onto the impact of node positivity, the survival comparison was done between the N0 group and the N positive group. And it showed that there was statistically significant worse prognosis in terms of both disease-free survival and overall survival in the N positive group, with the hazard ratio of 2.74 for disease-free survival and 3.49 for the overall survival. From this N positive group, the NS group, the single positive group, was selected, and the various clinical pathological variables were compared between the N0 and the single positive group of lymph nodes. And these are the various factors they looked into, which I am focusing on to the statistically significant variables. So the most important statistical variables which were significant were, the first was the depth of invasion. In the depth of invasion in the N0 category, it was 8 mm, whereas in the single node positive group, it was 10 mm, which was statistically significant. When we looked into the lymphovascular emboli, it was 58.7% in the single node positive group compared to 6.6 in the node negative group. Perineural infiltration was seen in 52% of the single node positive group, whereas it was 28.7 in the node negative group. And also when the differentiation was taken into account, poly differentiation was seen in 25% of the single node positive, whereas it was 12.5 in the N0 group. So there was a significant difference with the adverse factors when the single node positive group was compared to the N0 group. And with regard to the adjuvant treatment, in the N0, 46.5% didn't receive any adjuvant treatment, whereas only 6% patients in the single node positive group didn't receive adjuvant treatment. So to look upon the impact of the survival between the N0 and the single node positive group, they compared the survival analysis, and they could find that there was significantly poorer disease-free survival in the single node positive group, both in the single node positive group compared to the N0 group, both in the disease-free survival and in the overall survival, with the hazard ratio of 1.9 for disease-free and 2.16 for the overall survival. But the extranodal extension is the most important adverse factor with regard to the nodal pathological factor. So to look upon the impact of the extranodal extension, they took the single node group without extranodal extension, that is 121 minus 30 patients, and they compared the survival analysis with the N0 group with the NS without extranodal extension. There also, they could find there is a statistically significant worse prognosis with poorer disease-free survival and overall survival in the NS group compared to the N0 group. So then they looked into the survival among the clinical pathological variants in the single node positive group. What are the factors affecting the disease-free survival and the overall survival? The lone factor contributing to the poor disease-free survival was the location of the primary in the gingivo-buccal area compared to the tongue. The overall survival was also significantly worse in positive margins, that is hazard ratio 0.234 clear versus involved margin, greater depth of invasion, presence of perineural infiltration, and presence of extranodal extension. And adjuvant therapy had a protective effect on overall survival. So these factors were taken for multivariate Cox regression analysis, and when they looked into the disease-free survival, the most important factors that affected the disease-free survival were the location of the tumor in the gingivo-buccal area and the presence of perineural infiltration. And with regard to the overall survival, a positive margin, that is a clear margin, and the addition of chemoradiotherapy improved the overall survival, whereas the perineural infiltration had a negative impact on the overall survival. See, they also looked into the nodal features of the single positive node, and they could find that there is a greater hazard for recurrence and death noted with any size of nodal deposit or the extent of extranodal extension. There was significant worsening of disease-free survival and overall survival at a nodal deposit cutoff of 12 millimeter. The worsening of disease-free survival and overall survival was noted with an extent of extranodal extension at 1 mm, but the statistical significance was noted at a extent of 2 millimeter. So with this results, let me come to the summary of the whole article. We all know the metastasis to lymph node carries bad prognosis, and in the present study also, N plus node carried a significant worse prognosis with regard to disease-free survival and overall survival. And these are the two papers by Ulger and the Leyland, which also gave it the same report showing the node positivity causing decreased disease-free and overall survival. And looking at the prognostic impact of single positive node, NS group demonstrated poor disease-free survival and overall survival compared to the N0 group, despite there is no significant difference with regard to T classification, size of primary tumor, or margin status. 93% of the single node positive patients received adjuvant therapy. In univariate analysis, adjuvant radiotherapy enhanced overall survival, and multivariate analysis, adjuvant chemoradiotherapy enhanced overall survival. The impact of extranodal extension, we all know this is because of the importance of the extranodal extension. It has been incorporated in the AJCC 8th edition. And this is the paper by Alan Ho published in JCO showing that NS group without extranodal extension exhibited the poor disease-free survival and overall survival similar to that of our study, with a 59.43-year survival with one lymph node without extranodal extension, whereas it is 50.6 in extranodal extension and one node positive with extranodal extension. Coming to the impact of the extent of extranodal extension, this is a study by the Mamik published in the Oral Maxillofacial Surgery, where the cutoff was 1.9 mm, where in our study, it was a cutoff at 22 millimeter, negatively influenced both disease-free survival and overall survival. The size of the tumor deposit, it reflects the disease burden, and it is the reliable gauge of disease biology and ultimately affecting the prognosis. So any tumor size of any size in a single node positive node, it has got an inferior survival compared to the N0 group, and the cutoff was 12 millimeter. Topography of the nodes, in our study, all patients had a positive nodes at level 1, 2, and 3. So they couldn't do a meaningful analysis, and impact of the topography of the single positive node on survival parameters could not be determined. And this is at another study from the Brazilian Journal of Otorhinolaryngology, where they show that there's a significant difference in survival if level 4 and 5 is involved. And coming to the subsite, in our study, gingival-buccal subsite fared worse compared to tongue, and hazard ratio was 2.12 for disease-free survival and 2.55 on multivariate analysis. But this could not translate into better overall survival. And to look into the subsite, this is a paper published from Memorial Sloan Kettering Center, where they could found that during an unadjusted hazard ratio, gingival-buccal complex had poor over survival compared to tongue squamous cell carcinoma. But when the hazard ratio was adjusted, they couldn't find any significant difference between the survival with regard to the subsite. And this is another paper from Tata Memorial, where they found that group 1 patient, that is a gingival-buccal complex patients, had a better survival than the tongue and the floor of mouth region. So there is disparity in the results with this particular aspect. Coming to the perineural infiltration, I said that in the node N0 group, it was 28.7, whereas it was 52% in the single node positive group. So that is the only tumor factor that was consistently associated with the poor overall survival and disease-free survival on multivariate analysis. So this impact was well shown by so many literatures, and this is one paper published from Tata Memorial by Deepa Nair et al. It is an independent prognostic factor in oral cancer that warrants adjuvant therapy. And this is another paper from China, the prognostic impact of perineural invasion. That's a prospective randomized. And this also stressed upon the role of perineural infiltration in oral cancer prognosis. So the article concludes by saying that a single metastatic node, they showed significant differences in the prevalence of pathological risk factors compared to node negative patients. And within the single node positive population, the tumor factors like gingival-buccal subsite, perineural infiltration, and positive margins determines the poor prognosis, whereas the nodal factors that influence the survival were extranodal extension and the size of deposit. So these all factors has to be considered when we are looking at the single positive node. And adjuvant treatment enhance overall survival, but it needs to be validated in large prospective study. So what are the limitations of the study? The first limitation it's a retrospective data. So there is a lot of selection bias. The subsets include is only tongue and gingival-buccal area. The other subsets were not included. Maybe they be small in number. And the T-stage distribution, all stage T1, T2, T3, T4 all included. The heterogeneous group is included. So the impact of single node positivity in the overall survival will be biased by the advanced stage of disease like T3 and T4. And
Divya, may I interrupt? Because of the shortage of time, maybe your mentor can discuss what
And
are the
one more slide, only one more slide.
Yeah, yeah.
In details of perineural infiltration, like whether it is focal, multifocal, small, large, intraneural was not specified. And the strengths of the study, it addressed a common clinical scenario, creating dilemma in the treatment, which was not so far addressed exclusively. And the pathological risk factors pointing nodal metastasis were well explained. And this study is real stimulus to conduct a multi-center prospective study to address this issue in a randomized controlled way. With this, let me conclude my presentation. Thank you for your kind attention.
Thank you, Divya. Over to you, Mayuri, for the discussion part. Dr. Mayuri? Okay, Divya, can you just elaborate how far it can impact our clinical practice in the Indian scenario, like in the Indian subpopulation, whether we can implement this article for our future of our patients with single node positivity.
Yes, madam. In a clinical scenario, this is really a diagnostic, it's a treatment dilemma. Why? Because most of this is all personalized treatment they receive. Some people will give adjuvant radiotherapy. Some people will not give adjuvant radiotherapy based on the single positive node. As per the ASCO guidance, a single positive node should not be treated by adjuvant therapy unless the node has a extranodal extension, and if the tumor factors like perineural infiltration, lymphovascular emboli, or advanced stage are encountered. So in our study, what we saw that it is a perineural infiltration, the most important factor affecting the disease-free survival and the overall survival. So we should make a clear consensus how the perineural infiltration has to be. Pathologically, they should tell whether it is a focal, multifocal, large nerve, single nerve, and also regarding the perineural density. So a focal perineural infiltration may not be a indication for an adjuvant RT, but a multifocal perineural infiltration with a single positive node, that patient needs adjuvant therapy. So we have to look into the nodal factors. We have to look into the primary factors before pulling the patient or pushing the patients to a follow-up protocol than taking for adjuvant therapy. So we have to make a consensus in a single positive node which all patients needs to be treated by adjuvant radiotherapy. For
yes, to Dr. Mayuri, whether you can elaborate much on your trainees discussion. You are muted. No, you are not audible, Mayuri. No.
Mayuri, ma'am, we are not able to hear your voice.
Some technical problem there. It's okay, Mayuri. Maybe we can come back to you again after the third paper, because we are already out of time now. Now, Rajni, can you introduce the third team and we'll move on to the third presentation?
Yes. And now the Dr. Dhiraski present the paper, and the mentor is Dr. Smriti Panda. She is the Assistant Professor, Department of Otolaryngology, AIIMS, New Delhi. And the paper is neck dissection based on sentinel lymph node navigation versus elective neck dissection in early oral cancer, randomized, multicenter, and non-inferiority trial, which was published in JCO. I request Dhiraski to proceed.
Good morning, ma'am. Good morning, everyone. Can you please allow me to share my screen? 1 minute, I'm sharing my screen. Is my screen visible? Am I audible?
Yes, sir.
Good morning, everyone. Today I'm going to present the journal which has the title of neck dissections based on sentinel lymph node navigation versus elective neck dissections in early oral cancers, a randomized multi-center non-inferiority trial by head and neck cancer micrometastasis group led by Hashigawa et al. So my mentor is Dr. Smriti Panda, Assistant Professor in Department of Otolaryngology, Head and Neck Surgery, AIIMS, New Delhi. I am Dr. K. Dheeraj, Senior Resident in Department of Otolaryngology, Head and Neck Surgery. So to start with, surgery is generally preferred for oral cavity squamous carcinoma. With regard to the management of an N0 neck, there has always been a debate whether an elective neck dissection has to be done or it has to be based on a sentinel node biopsy. Even though we have level 1 evidence for elective node dissection, which has strongly conferred survival benefit. So continuing this conundrum, the head and neck micrometastasis group of Japan, led by Hasegawa et al., they have started this randomized control trial to investigate the best possible surgical technique for managing the node negative neck in early oral cavity squamous carcinomas. The primary endpoint of this RCT was a 3-year overall survival rate, and the secondary endpoints were post-operative neck function and adverse events, and a 3-year disease-free survival rate. So this was a prospective randomized multi-center non-inferiority phase 3 trial. And in this study, they have compared 2 groups, the experimental group of sentinel lymph node navigated neck dissection and the second group, an elective neck dissection in early stage oral cavity squamous carcinoma in terms of post-operative survival rate, safety, and neck function. So the inclusion criteria in this particular RCT were T1, T2, N0 oral cavity squamous carcinoma as per the UICC staging, and no cervical lymph node metastasis on a CECT of the head and neck, no prior treatment with a written consent, and the age being more than or equal to 18 years. And the exclusion criteria were T1 tumors with a depth of invasion less than 4 mm, patients who are having a recurrence after a definitive treatment, either a surgical or a radiation therapy, and history of prior radiation therapy, and presence of planned or current pregnancy, and any other disqualifying reasons as judged by the attending physician. The time period was between November 2011 to Jan 2016. So as per this methodology, 1:1 randomization was done by the statistical researcher, and they have been randomized into 2 groups. The one group, which is the sentinel lymph node biopsy group, and the other, the standard elective neck dissection group. Approximately 138 patients were randomized to each group. And the N0 diagnostic criteria for this particular RCT was a contrast enhanced CT was mandatory, and on a CECT, the maximum diameter for a deep cervical jugular nodes was more than or equal to 15 mm, and for level 1B, it was more than or equal to 10 mm. And along with that, the presence of central necrosis with an unclear boundary showing extranodal extension, fusion of at least 3 more than or equal to 3 lymph nodes, and asymmetry with the maximum diameter on the affected side, twice more than that on the healthy side, was taken to be a metastatic node. And to identify the sentinel lymph node, the radioactive dye used was technetium phytate, and the day prior to the surgery, 74 millibecquerels of technetium was injected equally into 4 sites in the peritumoral mucosa using a 27 gauge needle, and followed by, during the surgery, the tumor resection was performed, followed by detection of the radioactive sentinel lymph nodes with a handheld gamma probe, and subsequently a selective neck dissection within the sentinel node basin was done. So once the sentinel nodes were identified and they have been dissected, the analysis of sentinel nodes was a 2-stage process. During surgery, once the sentinel nodes they have been dissected, 2 mm thick blocks of rapid frozen section specimens were obtained, and they were processed. And if these were negative for metastasis or squamous carcinoma, these blocks were again paraffin embedded for a much more detailed evaluation using 4 mm thin sections, and they were subjected to hematoxylin and eosin staining and subsequent cytokeratin immunostaining. So isolated tumor cells which are less than 200 microns. So at the time of planning of this study, the relationship between isolated tumor cells and the prognosis of head and neck cancer remained unexamined. If we look at other subsites like breast cancer, there were reports, or there is abundant literature examining the correlation among the micrometastasis, regional lymph nodes, isolated tumor cells, and prognosis. So taking that into account, this particular RCT, they have included isolated tumor cells as metastasis positive, and they subsequently went ahead with neck dissection. So the neck dissections done in this RCT was supraomoid neck dissection. If the in the sentinel lymph node biopsy arm, if the frozen section was positive, a therapeutic neck dissection was done at one sitting. And if the frozen section is negative and the sentinel lymph nodes were subsequently found to have mets in the hematoxin reducing staining paraffin sections, a neck dissection was done within 6 weeks as a second sitting. And if the primary is in the floor of mouth, or if the primary has to be excised through a pull-through approach because of the shine-through effect, a supraomoid neck dissection was performed in the sentinel lymph node biopsy arm. So coming to the post-operative adjuvant treatment, the protocol stipulated that patients with extracapsular spread should receive radiotherapy within 6 weeks of surgery. The decision whether to add concomitant chemotherapy along with radiotherapy for these patients was left at the discretion of each institute. And additionally, for patients with positive tumor margins, whenever and wherever feasible, either a resurgery and or a radiotherapy with or without chemotherapy was performed according to the discretion of each including institute. So coming to the statistical analysis, the acceptable difference in the 3-year overall survival rate to have a statistical significance was set at 12% in this RCT. And the overall survival was evaluated using log rank test. If you look at the results, a neck dissection was performed in almost 98% of the patients in the neck dissection group, and only in 40% of the patients in sentinel lymph node biopsy group after a 1-stage or a second look procedure. And in the experimental arm, that is the sentinel lymph node biopsy arm, approximately 60% they did not undergo any neck dissection. So if you look at the baseline parameters, the primary site was majority tongue in both the arms, whether it is an elective neck dissection arm or in the sentinel lymph node biopsy arm. And the point to note is in both the arms, there was majority of the patients did not have to receive adjuvant therapy. And even in the sentinel lymph node biopsy, in which approximately 60% of the patients did not undergo a neck dissection, 97% did not receive any postoperative therapy. So if you look at the approaches for the primary, in both the arms, majority they were the approach was a transoral approach, and the pull-through approach was used in 19% in elective neck dissection group and 18% in the sentinel lymph node biopsy group. So if we look at the pathological node positivity of the sentinel lymph nodes, it was in the elective neck dissection group, it was 24.8%, and in the experimental arm, it was 34.3%. And but it was not statistically significant. So if we look at the sensitivity of the frozen section and not the hematoxin and eosin staining, when the frozen section was used, the number of positive cases was 24%, and when it was subsequently subjected to the hematoxin and eosin staining, it was 34.1%. And the subsequent overall sensitivity of this procedure was 68.5%. So if we look at the overall survival in the two arms, whether it is a neck dissection arm, it was 86.6% over a period of 3 years, and in the sentinel lymph node biopsy, it was 87.9%. And since the non-inferiority margin of the sentinel lymph node group was set up as 12%, the 3-year overall survival in the sentinel lymph node biopsy group was not inferior to that of the neck dissection group. Similarly, if you look at the disease-free survival, the disease-free survival in the experimental arm, that is the sentinel lymph node biopsy, was 78.7%, and in the neck dissection arm it was 81.3%. And this was also not statistically significant. The functional analysis which was done for the secondary endpoints was with the arm abduction test and neck disability quality of life questionnaire performed at 1st, 3rd, 6th, and 12 months after the neck dissection. So the functional analysis, the neck stiffness was worst at 1 month post-operatively, and it improved subsequently over time. The scores at 1 month, 3 months, 6 months, and 12 months in the sentinel lymph node biopsy group were significantly better than those in the neck dissection group. And the other scores such as constriction, pain, numbness, shoulder drop, and arm abduction test, all they showed similar trends. That is, they were initially worst at the 1st month and subsequently in the sentinel lymph node biopsy group. and subsequently with progression of time, they have improved. And coming to the recurrence pattern, the false negative rate, which means the sentinel lymph node were negative for any nodes, but subsequently they had a regional recurrence. So the false negative rates of metastasis in the neck dissection group was 10.5%, and it was 15.1% in the sentinel lymph node biopsy group. Coming to the adverse effects in the elective neck dissection group, the rate of adverse effects was 14%, and in the selective sentinel lymph node biopsy group, it was 9%. So this RCT, they had concluded that sentinel lymph node biopsy navigated neck dissection is not inferior to an elective neck dissection, and also it is less invasive than an elective neck dissection in early oral cavity squamous carcinoma. And it should be promoted for a more widespread use of sentinel lymph node biopsy guided neck dissections, particularly in early stage oral cavity squamous carcinoma worldwide. So prior to this RCT, there was one more RCT which was an equivalence trial, which tried to head-on compare the two modalities, a sentinel lymph node biopsy versus elective neck dissection, which was equivalent to which modality, led by Ronald Garrel of the French group. So if we look at both the trials, the Japanese Hasegawa trial, the primary endpoint was 3-year overall survival. The secondary endpoint was functionality and disease-free survival, and it was a non-inferiority design. And this French group, led by Garrel, the primary endpoint was a 2-year nodal recurrence-free survival, and the secondary endpoint was 5-year nodal recurrence-free survival, disease-specific survival, and it was designed on an equivalence model. So the patient inclusion criteria group was T1, T2 only oral cavity, and majority were tongue. And patients with tumors with a DOI of less than 4 mm were excluded, and majority were stage T2. And in the French group, they have included both oral and oropharyngeal tumors, the majority being the oral cavity, and the T2 stage were more, it was 35%. So the dye used, or the sentinel lymph node biopsy technique they have used, was a technetium-58, but the radioactive material which was used in the French group was not reported. And the point to be noted is the isolated tumor cells were included, and they were taken to be positive for metastatic nodes in this Japanese Hasegawa trial, but the ITC were not considered to be metastatic in the French group. And to section these sentinel lymph nodes, a frozen section was used, and subsequently, if the frozen section was negative, there were paraffin embedded, and they were subjected to the hematoxylin eosin staining and immunohistochemistry. But in the French group, a frozen section or an imprint cytology was used, and then they were subjected to a step serial sectioning. The pathological node positivity rate in Japanese trial was 35%, and it was 25%. And 3% of patients in the Japanese trial, they had received adjuvant treatment, while it was approximately 25% in the French group. The survival outcomes, the overall survival was 88%, and the DFA, disease-free survival, was 78%. And the French group, the 2-year nodal freeze recurrence rate was 90%. And the functionality was better with the sentinel lymph node biopsy in both the studies. And the sensitivity of the frozen section or intraoperative analysis was more or less similar in both the trials. I request now Dr. Smriti ma'am to take over the critical appraisal part. Ma'am, shall I share the screen?
Can you stop your screen sharing?
Yeah.
So, yeah.
Should I share my screen now?
Is my screen visible?
Yes, ma'am.
Thank you, Dr. Dheeraj, for your excellent presentation. So I will skip the results part. This was a non-inferiority trial, and they have reported the results with a very narrow confidence interval with more than 80% follow-up, and therefore this study falls under a level of evidence of 1B. And we have also assessed the risk of bias according to the criteria laid down by Higgins and Altman. And the risk of bias was found to be low in the area of random sequence generation and allocation concealment. However, blinding of the participants and the outcome assessment was not done, and therefore only in this particular domain the risk of bias was found to be high. However, this high risk of bias is of minimal clinical significance because it is unlikely to affect the results of this RCT. And all the pre-existing outcomes which were committed to in the protocol have been addressed in the final results, and therefore there is no selective outcome reporting. And for the post-randomization dropout, the investigators have performed a full analysis set. So again, the risk of bias is low in case of incomplete outcome data reporting. And in terms of funding, since it was a government-funded research project, then so again in this domain, the risk of bias was found to be low. So this was a phase 3 RCT, a non-inferiority trial with a very homogeneous data set, and the two arms were perfectly balanced by the minimization technique. And this was also adequately powered, and the sample size was found to be adequate. So this was a very robust RCT, and by the means of this RCT, they have demonstrated that we can safely avoid neck dissection in almost 60% of these patients with a very good shoulder outcome and quality of life. And the investigators have also shown us that even if the primary is located in the floor of mouth, one can avoid the shine through phenomena if the primary is excised before proceeding with the sentinel lymph node navigation. But still, we have noted few limitations in this study. The staging has been performed according to the AJCC 7th edition, and therefore the depth of invasion was not taken into consideration in the randomization process and the minimization process. We feel that a 12% non-inferiority margin may be a bit high, and a lower non-inferiority cutoff may have required a larger sample size accrual. And also, since sentinel lymph node biopsy technique requires dedicated infrastructure, skilled workforce, and multiple surgical procedure, a cost effectiveness analysis could have been presented and would have been worth comparing between the sentinel lymph node group and the standard neck dissection. So even after reviewing the two RCTs, there are still some points of contention which need to be cleared. So are all T1 and T2 N0 early oral cavity cancer suitable for sentinel lymph node biopsy technique? In the article which was published in Head and Neck based on the consensus guideline for sentinel lymph node biopsy, we should pay equal attention to the anatomical location of the primary site apart from these T and N category, because sentinel lymph node biopsy technique makes sense only if the primary is resected by the per oral route without the need for neck access either for reconstruction or for the resection. So is there a DOI cutoff for deciding between elective neck dissection and sentinel lymph node biopsy technique? Again, it would be logical and more cost effective if we restrict sentinel lymph node biopsy to patients who are unlikely to, who are not likely to have a very high occult metastasis rate. This is based on the UK guidelines, where it has been suggested that standard neck dissection should be given precedence over sentinel lymph node biopsy if the occult metastasis rate approaches 65%. In terms of isolated tumor cells, there is currently no guidelines whether presence of isolated tumor cells actually merits a N+ status, and whether these patients should be subjected to adjuvant treatment. In the European SENT trial, as well as in the French group RCT by Garel et al., the prognosis of the patients with isolated tumor cells was found to be very similar to patients who were pathologically N0. And in the Garel trial...
Dr. Smriti, may I interrupt? Our time is over. Maybe conclude, because the other session has to be started. Sorry. Okay. And Dr. Tashni, maybe you can stop with a concluding remark. Dr. Tashni? Okay. Yeah, you are muted. Okay, no issues, Tashni. Some technical problem at your side. Yeah.
Yeah. Now you can hear?
Yes, yes.
Dr. Mayuri was supposed to speak, I think. Dr. Mayuri.
Only if I'm audible again. Am I?
Yes.
Okay. Yeah, only 1 minute for us, maybe.
Yes, I'll be quick. I think I put up my comments on the paper that Dr. Divya presented on the chat
seen.
panel. So it's just that it is a very good paper looking at within the node positive, particularly N1 group is also a heterogeneous group. It highlights that there aren't the AJCC 8. Classification now upstages nodal disease with extranodal extension, and these tumors, the ones in the author's study were probably staged as AJCC 7. So there might be a lot of N3 nodal disease in that, but they have done that N1 without any subsite analysis. However, what we must understand is even in the ASCO guideline, the N1 nodal disease not requiring postoperative adjuvant therapy is a moderate recommendation. Also, it comes with a caveat that it should be a high quality neck dissection. Now, high quality, yes, doctor, there is a mention that the quality of neck dissection, the nodal yield should be above 18 lymph nodes. But again, there is no standardization, and you cannot,
I'm telling you, keep it on.
So, so there may not be any, if the nodal dissection is not standardized, that can lead to problems. And also, this opens up an area of prospective study, that is N1 nodal disease, early stage oral cancer, and within the N1 without extranodal extension, to look at one, size of nodal deposit and its impact, and the subsite of the primary tumor as well as the node topography, and then make recommendations on whether adjuvant treatment is an over treatment, or is it can we do without adjuvant treatment.
Okay.
Thank you. Thank you,
Okay,
Dr. Mayuri.
Thank you. I think we have to wind up.
Because we are over time now. All the presentations were really excellent. Congratulations to all the trainees and all the mentors also. Now we need to move to the other session. The next session is HNCOPE session, which will be moderated by, I welcome Dr. Subramania Iyer. Sir, he's the professor and chairman of the Head and Neck Oncology and Reconstructive Surgery at Amrita Institute, Kochi, and Dr. Amit K. Dinda, the Emeritus Scientist of the Department of Pathology, AIIMS, New Delhi. Over to you, Dr. Iyer and Dr. Amit Dinda.
Thank you, Elizabeth. Dr. Dinda, Amit, you're there, no? You're there. Okay.
Yeah, I'm here.
I'll just start off introducing the whole session, and then you can take over later on. Is it okay, Amit?
Yeah, it's fine. Thank you.
Okay. So it's welcome to you all for the HNCOPE session today morning, and thank Vikram and Alok for giving this opportunity for HNCOPE to be part of this meeting in this session. And when we thought about the session, we thought that we should talk about something, some of them, we are all into technological innovations that have been introduced into the field of head and neck oncology. So, and oncology in particular. So we thought that this session can be useful to all those people who are aspiring to capture or, involved in such sort of activities. And we have excellent speakers in this. Dr. Duvuri, Dr. Kuriakos, Dr. Vishal Rao, and Kumaresh, all who have excelled in their fields in utilizing technology in head and neck cancer care. So let me start. Momesh, Momesh, you're there, no?
Yes.
Oh, yes. Welcome.
Nice to see you.
Nice to see you. Great. Dr. Duvuri is somebody who is synonymous with technology in head and neck cancers internationally. And he is a person whom everybody can look into. Youngsters can look into how you can evolve into a technician scientist, I would say, rather than Moni's favorite word of clinician scientist. Uma Maheshwar has paved the way for developing robotic technology in head and neck. So I won't. I will just request him to talk to about, because the only reason why the topic was selected for him was that he has shown us how to proceed with that. Designing devices, getting them approved was his topic. Over to you.
Thank you, Professor Iyer, for this kind invitation to the panel, also to Professor Tucker and the team for this for putting this all together. I'm sorry that I'm not able to be there in person, but I am very grateful for this opportunity, and I hope I can take the next few minutes to talk a little bit about the topic that I was assigned, which is designing devices and getting them approved. I think you can all see my screen, hopefully. Is that okay?
Yeah, great.
Yeah, perfect. Okay. So this is sort of a broad ranging topic. And so I wanted to take you down sort of my journey with this concept. And I think the reason I was asked to speak on this topic is because of my intimate relationship with having designed and developed and taken into commercial utilization a robot called the Med Robotics robot, the Flex robot, which unfortunately the company has gone out of business. So I will give that as a sort of a disclaimer that this is what has happened for many reasons. I'll talk a little bit about that. But rather than speaking about the very technical nuances of this topic, I thought I would give the audience and hopefully the younger people in this group a flavor of what is the concept behind this sort of approach to technical innovation. I know I had a very talented fellow who trained at Tata's when I was a resident, now he's a professor, Rohan Valvekar, who taught me very importantly as a young surgeon that it's not as critical to memorize the steps of an operation, to memorize the particular nuances of the steps of an operation, as it is to understand the concepts of an operation. And so I think if people understand the concepts of this technology and the concepts of what we do, we can impart this knowledge much more efficiently. So in the interest of time, I'll jump right into it, having given that sort of preamble. The future of medicine is now. And I think that we should continuously think about what we can do to improve the quality of care for our patients. We know that our patients want to recover more quickly. They want to have less downtime, as we say. They don't want to be taken away from their life. And this requires technical innovation and, most importantly, the translation of that innovation to patient care. And this ultimately boils down to a partnership between science and industry and how we can move this forward. And I'm going to use robotic surgery as an example because that's what I have done for most of my career was work on robotic surgery. And so the important thing to remember here, of course, is that most of what we do is not really true robotic surgery. It's not a truly independently or autonomously operating robot, but rather the robot is a surgical tool that assists the surgeon to manipulate tissues. And the most important robotic system that we have at our disposal now is the Da Vinci robot. And this is shown here. This shows a console, and then where the surgeon is sitting and working on a console that operates a robotic cart, which is designed to be placed remotely from the console, right, at a different distance. And it's important to remember that this robot was designed to improve care in combat situations, mostly because surgeons are not particularly aggressive in being involved in conflict. And so we are scaredy cats. And so surgeons want to sit carefully and take care of people. We don't want to be involved in combat situations. So the US Department of Defense actually designed this system and funded the development of the system to be able to have a surgeon sitting inside of a particular area that could then have these carts in multiple places that can then be used to take care of patients. Okay, and the way that this works, as many of you know, is that the patient side console is positioned, what we call docked, and then the robotic arms are introduced into the patients. either through the thoracic cavity, the abdominal cavity, if you're talking about trauma or abdominal procedures, or through the mouth for transoral surgery, which is what most head and neck surgeons will use. And then the surgeon operates the remote console. Now, I want to take you a little bit down the memory lane so that you can understand why this is important. So the story of Da Vinci development is really summarized by the statement at the top that was written by this really talented and very, very important surgeon in our field, Indrabal Gill. And so Indy Gill at the USC Keck School of Medicine said that Intuitive shot for the heart, but they hit the prostate. And that's because heart surgery was considered to be the most important aspect of surgical technologies. And the reason for that is that tremor reduction was thought to be the critical aspect of the robotic surgery, right? So if you could reduce tremor, then you could do surgeries that did not require tremor. And the most important one for that, of course, was the cardiac surgeries. And so people thought, well, Da Vinci surgery should be great for cardiac surgery. Well, Indy realized that although the robot could be used for cardiac surgery, one of the other key elements of this robotic system was that it could give you triangulation and really, really great magnification view of a very specific part of the anatomy. And being a urologist, of course, for him, the prostate was the key organ that he was interested in. And he realized that the robot could be used to get towards the prostate. So having pioneered this field and done the first robotic prostatectomy, which took him actually 6 or 7 hours, if I remember correctly, when he reported this in the late 90s to the early 2000s, this became an area that was, well, maybe it's interesting, but maybe not. Well, Vip Patel, one of my friends and mentors, who's now at Advent Health in Orlando, Vip realized that this could be a way that could really push this field forward. And when he was a junior faculty member at Ohio State, really pushed this field forward. And now he has done over 15,000 prostatectomies and has shown truly the value of this technology. So the point is that many times we need to see a technology or realize what a technology can do beyond what it is told that you can do with it. You need to look at the tool and realize that it is not only about hitting one particular nail, but rather that a tool can be used for multiple applications. And that means that you must be able to think a little bit outside of the box. And that's what I encourage all of us sort of to reflect on. Why use a robot in surgery at all, or specifically in head and neck surgery? Well, as I said, the robot allows dexterity in hard to reach areas. And so it allows for tremor reduction. It allows for improved visualization. It gives you 5x magnification, much more so than one could get with surgical loops, for example. It gives us wristed instrumentation. And so it would seem that this was a very great tool for operating in areas that are hard to reach. And one such area for us as head and neck surgeons, of course, would be the larynx. And so when I was a medical student at the University of Pennsylvania, Neil Hochstein was a postgraduate trainee in otolaryngology, head and neck surgery at the time. Joe Wu, who was one of the fellows when I was a medical student, became a young faculty member as a cardiac surgeon who was tasked with developing minimally invasive cardiac surgery. And he started doing a lot of cardiac surgery work at the time. And Neil approached him and said, you know, if you can use this robot to sew without tremor, maybe we could apply it to an area in head and neck that also requires tremor reduction. And a really particular area for that is laryngeal surgery. And this fundamental concept, which led to development of this whole field of TORS, came not from some big professor, but came from a postgraduate trainee. And so I really want to highlight this because you guys may not know this in the field, and tell the postgraduates that you are just as capable of asking a very, very important question, which is, how can we do things better? Now, at the end of the day, robotics and laryngeal surgery turned out to be okay. Yeah, reduction of tremor was good, but the access was poor. The instruments were too large, and Hochstein et al. They were able to publish this paper in robotic microlaryngeal surgery. yeah, in a surgical robot using a mannequin. And you can see here that this is a paper with Neil Hochstein and Joe Wu. Bert O'Malley, as the chair of the department at the time, was very keen on seeing this and promoting this. So it's so important to have a head of department that is willing to embrace this vision. So what's the common theme between Indy Gill and Neil Hochstein? Number one, collaboration. You must have buy-in from other departments. Don't live in your little box. Don't think of yourself as, I am the head and neck surgeon and this is what I do and this is all that I do. You have to be able to understand what other fields do because you can gain so much knowledge from them. Number two, have an open mind. Don't think of yourself again as being so limited that you cannot even conceptualize or imagine what the world might be like outside of your little box, right? We all live in our boxes, we all work in our spaces, but we must have an open mind. And if you can have these two themes, I think that you can really help to push the field forward. As far as devices go, it was clear to us at the time in 2009 that TORS with Da Vinci surgery was great. It was approved. It was good for these indications. And it was wonderful because so many people have oropharyngeal cancer in North America and have sleep apnea and potentially have tongue-based surgery. And we could do this kind of surgery with robots in the mouth. But it also told us that being able to avoid these big surgical procedures with this existing technology was great. But there was a big but, that given the fact that we could improve the outcome for these patients, we could improve the care of these patients. There's a particular patient of mine who did very well with transoral surgery, with Da Vinci surgery. We still recognized that there was a gap. We still recognized that this technology had to be disseminated. So our group worked hard to study this. We published many papers on robotic surgery, but most importantly, we studied it from a clinical trial perspective. And this is now evident with the recent JCO publication of ECOG 3311, which led us to really critically interrogate whether this technology was really useful and applicable. And that is a really important point. No matter what technology you think you're using and you think is good, you have to really study it. You have to understand enough to be able to lecture on it and to teach it. Now, having said that, there were clearly big limitations to this technology, mostly cost. It costs a lot of money to buy a Da Vinci robot, and so this limits access. And also, very importantly, these are big instruments that are being put into the mouth of a patient, right? So you're using 8mm instruments in a very tight space. So at that time, it just so happened that I was in the surgical lounge between cases, and I met a colleague of mine who was a cardiac surgeon, Marco Zanatti, who told me that he was working with robotic scientists at Carnegie Mellon University, which is just about 2 kilometers away from us at the University of Pittsburgh. And I said, this guy is developing this robot. It's a snake-like robot. And I said, wow, very, very interesting. And this is what the first snake robot looked like from my colleague's laboratory, Dr. Howie Choset at CMU. And I said, this sounds very interesting for head and neck applications if the robot could be miniaturized and could be used to go through the mouth, because putting a straight stick instrument inside the mouth doesn't make a lot of sense. Right? We can do work with it, but it's not perfect. And so Howie and I decided to work on this, and very quickly we developed this sort of robot, and a highly articulated robot that could then be used to drive through the mouth into the laryngeal space, because once again, we thought this was very interesting. And this is what the video looked like at the very beginning prototype inside a cadaver. You can see it's very blurry, not particularly elegant, but we could get all the way to the larynx. And I thought this would potentially have great applications in the head neck space. And so what we realized is that the key to success in this area is not merely having engineers or surgeons or scientists as a branch of engineering or industry partners, but really to have this threefold partnership, or this 3 legs of the stool. Remember that most industry engineers are just that, they're engineers. They've never taken care of a patient. They have no idea what the real problems are that we face as we move through this. And so what we recognize is that in the process of developing a tool to get to FDA, not only must you have the buy-in from the clinicians and the scientists, but the industry partners should be excited enough to move this forward. And there are a couple of ways to take this through the pathway. One is through predicate device, which means that you're developing on existing technology. And that's the tool that MedRobotics went down, the road that MedRobotics went down. Or you could have a de novo pathway where you have to do the entire phase 1 through phase 3 trials, which is another very challenging pathway. But no matter which pathway is taken, the bottom line is that the engineers have to partner with the clinicians. We must not allow the companies to make robots and design or any tool that you would think, whether it's a robot or even a cautery, and then decide that you cannot then move this forward. And so this is the pathway that we had from the first in snake robot all the way to the commercial system. I'm almost finished with the talk. I know my time is up, but I'll just beg the indulgence for 2 minutes to go through the last 2 slides. I think it's quite important. From the first prototypical robot all the way to the commercial system, there's many areas here, including technology transfer, prototypes, first in market, and finally the commercial system being developed. And the clearance timeline is also quite long. It can take well over 2 years for something like this to go through process, but requires input at every step from the surgeons. And as I said, there are many pathways that exist to do this, either predicate device, novo submissions, and finally post-market surveillance to ensure that the robots are working at the level that they should be, or the devices work at the level that it should be. So having said that, I think that the future is really quite bright. This is a brief video showing how this technology can actually be developed and used in multiple different areas, including here using a luminous fiber to propose this kind of a technology in application. But ultimately, what we have is a need to create a system where surgeons can work with industry in a back and forth fashion. And this is what we have created at the University of Pittsburgh to create what we think of as a cross-fertilization platform to ensure quick commercialization. I think that this is a model that could be very well developed at throughout the world. And ultimately, this is a robot that's used now, this is at our Science Museum in Pittsburgh. This is a robot that's used to play basketball. You can see that this robot now takes this basketball and can throw it through the hoop with 98.6% accuracy. So one day we hope that surgery can be nearly this accurate. And so I think the future is really bright, but it requires that us, and particularly the next generation, think about the problems that we need to solve. And I really fundamentally believe that we should never do anything because the professor said so. You should do something because you actually understand the concept behind why you're doing it, what is the problem that's being tackled, and always ask yourself the question, is there a better way? And if you can do that, I think that we can really move this field forward and optimize the care of our patients to the best of our abilities, as has been demonstrated, for example, by Professor Iyer in his elegant work. So I thank the team for allowing me to give this presentation. None of this work would be possible without the members of my laboratory. And finally, Claudio Cernea, sent a wonderful colleague of mine from Brazil, sent me this thing that says, this is a small cartoon here. It says, the one who works with his hands is a craftsman. The one who works with his mind is a scientist. The one who works with his heart is an artist. But the one who works with his hands, minds, and heart is a surgeon. And so I think it's very important for us to remember that important aphorism. So thank you so much for your kind attention. And I apologize for being a couple of minutes over time.
Thank you very much, Umesh. That's excellent talk. I think it was really, thoughtful sort of final concluding remarks. There was one question. Could you answer in the chat box? Everybody can see it. Akshat Malik had put a relevant question. How do you get the industry partners interested in your work? If you could type your answer, it might be good, because we'll move on to the next lecture by Moni on technological Moni. It was a sort of, anyway, we are looking for your talk, right? Amit, can you take over now after that?
Yeah, sure.
Can I get right to share, please? Thank you. Yeah. Okay.
You said technology interruptions, no?
Technology disruptions.
Shall I start, sir?
Yeah, please.
Okay, thank you. Appreciate it. Hope you can see me and hear me.
Yes.
Yeah. Go ahead.
Okay.
Full screen.
Thank you, Subbu and Professor Dinda, and ladies and gentlemen, good morning. And I got this challenging topic assigned to me, that is the promise of technological disruption in head and neck oncology. Now, let me start with the common statement we all read in our most of our literature, that despite aggressive multimodal treatment, cancer outcome has not improved. Unfortunately, that remains true in 2021 too. Okay. Now, I want you to pause and ponder on this statement. Okay, it's quite appropriate that I'm following Uma, his talk. Just think about this. Electric light bulb did not come from the continuous improvement of candles. We do have candles, but the candle got replaced by electric bulb. Some innovation outside came and destroyed or destroying that candle industry. We are seeing that in day-to-day life. When you, in Subbu and in my generation, we have seen several technologies like Xerox and Kodak, and my favorite BlackBerry all died. Okay, who came instead of that? Big IT industries like Apple, Google, Amazon, and everything changed. They've come, disrupted the industry, and took over for the best. Now, coming back to head and neck cancer, this is a prediction of mortality in head and neck published by Patterson's group. They estimated, based on the previous data, what would be the mortality from 2016 to 2031, and showed that globally there about 38% worsening of outcome. And most this happens in Asia and sub-Saharan Africa. But I want you to look at the good side, the blue side. Central Europe and other certain countries have got an improved outcome up to 15%. But look at where Uma comes from, no improvement. Technology doesn't improve. Something else is what is predicted to improve, okay? And now if you look at some of the recent publications from individual universities and the hospital showed even better improved outcome. So how does that improved outcome comes through? So this is, they looked at various parameters like income. Okay, better income you have, better outcome. And as a performance of the healthcare indices, they use surgical workforce as a surrogate marker, and showed that more number of surgeons you have, better outcome. This correlates with the income of a country. That shows that it is not the technological evolution of a country or a population, but it is sheer performance of a health system that improved the outcome. Now, to improve the performance, we need to walk the path of one patient at a time, and then we can translate into 1.2 million patients. And if you look at that, we all know from literature that about average 6 months patients wait when they see a doctor, a medical doctor, until the patient get diagnosed. They have to go through this convoluted pathway, and then people like us manage the patient. No wonder they're doing as well as it does in a very, very difficult place such as us. In country like India, it's not just a standard. We have rich and large India living together with multiple expectations and so on. Cancer burden is increasing, advanced stage is happening, poor adherence to treatment compliance and rising cost, everything is happening. And if you just ask anybody, rich or poor, what is really cutting through that society is the two questions, cost and access. Now, the question is how to improve that. I believe there's a solution coming from outside, not from within, outside. I believe that technology would be the biggest equalizer. And I believe that the Pattersons will be proved wrong. And I believe technology will bridge the gap. This picture is from Subbu's town, Thrissur. Those who are familiar with knows about it. This is a picture taken from the internet, 2009 and 2019. If you zoom in 2009, look at that number of people using mobile phone. They're not watching directly through the mobile phone. They are. So technology is all pervasive. I want you to join me in a thought exercise. Imagine that all of us are there to handhold that patient who has gone to the village, primary care doctor and everything. I'm pretty confident that we would have had a better outcome. But we cannot clone Dr. Elizabeth or Subbu Iyer or Dinda. We can't do that. Now, imagine that we pool all that knowledge, not just surgical knowledge, diagnosis, pathology, and everything into knowledge base, and use technology to deliver the cancer care in a hierarchical fashion and provide the appropriate technology where it matters. For example, early detection, you need separate technology. A complex robotic surgery, you need separate technology. And then the robotic surgeons or the complex centers should focus on that. They should not just dabble on early detection and other part. They just focus on what they do, best of knowledge, and do that in a seamless technological architecture. I believe it is possible. About 3 years ago, 3.5 years now, close to 4 years ago, government offered me a position to work in Cochin Cancer Center, first time in the government sector. And the government asked me to take up a challenge, whether we can manage, or we call it district cancer control program. It's in a Ernakulam district of 3.4 million. And the challenge was whether we can integrate primary healthcare with the cancer care. And 3 groups were there. The knowledge partner was a cancer center, and the delivery partner was the primary health doctors, as well as district hospital where they do surgery as well as biopsy and everything. And I will not bore you with the details. And during 2020, about 6 months after execution of the project, we had trained about 700 health workers, 80,000 people were empowered. This process undertook about 600 odd biopsies, over 150 or 170 cancers or neoplasms were diagnosed. What is interesting is that the median biopsy turnaround time was 6 days. Even in Subbu's place, we'll not get this. Okay, and the compliance was pretty good, about 86%. This was in 2020, peak of COVID time. Okay, the process worked. Now, think about, that was a very physical model. Now think about the whole thing is digitally managed. Start with the digital apps. It is an app with the various technology. I will not go into details of that. And this is what I do these days. I work for an organization called Fhno, and supported by Tata's. And then we are piloting in the state of Kerala. So in addition to that Ernakulam district, we have taken up another district, Idukki. Idukki, by the way, is a very hilly area. People have gone for tourism in Munnar. And this is one district is highly inaccessible, okay? And it doesn't have a cancer center. And we want to see whether we can make the entire community as a cancer center, not just one place. And our plan is to have 70 community cancer centers, and they execute in a hierarchical fashion with centers like Amrita or others will be the apex cancer center to execute the care. And the whole thing is navigated through a navigation center or central command center. and that monitors the care. And then we have the stakeholders are patient, caregivers, doctors, lab technicians, and so on. The care delivery happens in a various level, from early detection to biopsy, like similar to the district cancer control program. Biopsy carried out certain place, investigation happens at certain place, part of the surgery happens in certain place, some radiation happens in some other place, and so everything orchestrated through a central command center with the various partners involved that use technology to drive the entire cancer care, so the entire community become a cancer center. And this is a reality now. It's happening now. This is the data from one center. This is where Dr. Iyer comes from, Thodupuzha. This is from a small hospital there. During about 3 months period, about 1,300 patients were screened. 48 cancers were diagnosed. Most of them were early stage cancers. And chemotherapy, never used to get chemotherapy done there. And one of my colleagues, students only, Suraj and others, have done surgery there. And the patients travel all the way to Ernakulam to get the radiation done, or planned centrally, or at least part of it planned centrally with a digital tumor board. We plan it with the experts from all over the world, plan it, and then go to the place to execute appropriate treatment and go back. So this is happening. Now, we can even improve on that, okay? This is something very close to my heart, how technology can for early detection. You all heard about Dr. Shankanarayan's work. This conference is organized at RCC. This is RCC's work, showed that you can just train health workers. But if we ask what happened to that paper, it's remaining as a paper in a library. So our question was whether we can replace health workers' eyes with a mobile phone or not, a smart mobile phone. This device has got both the white light as autofluorescence imaging, as well as use the phone's computing power to interpret the image or send the data to the cloud, and then cloud architecture diagnose yes or no. And then we deployed that in the northwest of India, northeast of India, in a population of about 5,000, 32,000 scans were carried out. And we compared frontline and on-site specialists. I will not go into details. Essentially, the accuracy of frontline health worker was 70, with the 4 neural networks went up to about 79. Cloud architecture was 87, which is comparable to you and me looking at that image. So the technology is getting better. So technology has the power to transform. We have seen that. And technology also has the power to disrupt. Now, if you look at the staging system, we just use fingers or scale to measure, and amazing that's doing as well as it's doing. But we know that we need the various additional markers where the depth of invasion brought in, extranodal extension came up, and the nomogram was brought in. So that included TNM with additional parameters, showed that nomogram can predict the outcome. Even more complicated nomogram was brought out. This is from Snehal Patel's group. What is predicted and what actually happened appears to be fairly good. This is a cohort about 600 patients. Now, this appears to be the norm. Is all right, it's going to come. We thought it's going to come. Here comes another paper, came up a few months ago. What they did was looked at NCCN data of about 6,000 patients, okay? And they just did not use what we all considered as the predictor outcome. They pulled in every possible data and compared the nomogram versus the machine learning model, and look at this one. The machine learned or predicted better than the nomogram. So imagine what's going to happen to AJCC, UICC. They will go out of the business. And this is happening. Now, let us say that they came up with this algorithm based on US population, and we say that, oh, we need to include buccal mucosa and everything. It's an Indian problem. It's our responsibility. I challenge all of you, if the key leaders are here, put in all the data. Let's come up with a machine learning algorithm to predict the next staging system. I know I don't have much time. During my time, I just talked only the technology, the biotech and other gene editing and other things will come. But machines have started gaining new insight, disrupt clinical care. I will end with this slide where I started. Whether we're going to change the outcome, I believe it's going to happen. And it doesn't happen from within, it will happen from outside. And we should be the driver of the new revolution. Thank you very much for your attention.
Yeah, thank you, Dr. Mani. It's a really exciting talk. And obviously, because of lack of time, I think we will not be able to discuss. But I think your point is really, very important, particularly for Indian situation, the different kind of problem which we face. So we should develop our innovation and technology development. So with that, I think we can thank you for this chair. And now we are going to the next speaker. But before that, I would like to thank the organizer and especially Professor Thakkar to give me the opportunity to chair this session. And the most important, the challenge now world over, including India, is that how we translate the innovation for bedside medical practice. And not only the translation, but important is that whether we can develop a commercially viable technology, which will be very useful and sought after. So with that note, I think I'm requesting Dr. Vishal Rao to present his talk, Driving Oncology. Yeah, please go ahead.
So I'm not able to share the screen.
Yeah, can you allow him to share the screen?
Okay, now I'm allowed. Thank you. A very good morning to all of you. I first of all thank the organizing committee for all the efforts and moderator Subbu sir and all the team here for all the encouragement and support that HNCOG has been giving us. I'm here to speak a little bit about innovation and tech disruption in oncology. So without much ado, I'm representing HCG. We are a small chain of cancer centers. Now we are at about 26 centers across the globe. And I'm going to start this entire discussion, maybe putting a perspective on looking at what Winston Churchill told in the World War II about Russia. He said it was a riddle wrapped in a mystery within an enigma, but perhaps there is a key. Today, when we actually sit down and look at COVID, it does not seem any different for us. That these words in the 1930s, which he spoke about, actually seem so relevant even for us for COVID today. And COVID has actually taught us a lot of wonderful lessons on innovations. And I'm just going to start with that note because I thought COVID has changed the perspectives that we've had on innovation, and the world post-COVID will be a different place for innovators. Now, we all know the story of COVID. I'm not going to go boring into this, but what's interesting is a few grams of this virus stopped the world. So if you look at it, many people call it the World War C. What it did was help us rethink, and I'm not going to talk about the deaths, miseries, but talk about what actually it taught us. It actually brought out a lot of pandemic CEOs in this entire world, and that for me was the most motivating part of this pandemic. That it taught us about how you should have a stratagem. That is, when you win a war without a strategy, when you win a war without fighting. So there were a lot of lessons that we learned during this particular COVID pandemic. And I've been closely going through pandemic CEOs. Pandemic CEOs are people who stood from behind and actually led the show, not going in front and saying, I'm the one who's going to do it, but actually stood with leadership behind to allow people to actually do it. And this is what my previous speakers, Moni sir and Duwari, were alluding to. And I think that was something that is going to be a hallmark post-COVID. We won some wars, most of them in the homes, not in the hospitals. We learned about a new age of productivity where we did not compete but collaborated at most places. We lost common sense in addition to the sense of smell. And there were a lot of lessons on reverse mentorship. There were no single experts. And this, I think, has paved way for conscious capitalism beyond just looking at GDP. Now, I think for me today, one of the things that I wanted to share was how important reverse mentorship was during this period, and how essentially it taught us about that there are no single experts, and sometimes the more mature will have to learn from the person who may not know anything. And this was actually a very interesting model for us, because if you look at translational research from bench to bedside, on an average, bench to bedside takes about 17 years. And this has been well studied because of the complex. So I was interacting with one of the drug controllers, and he told me, Vishal, most of the times when I sign a particular order for basic research, preclinical studies, it is the third or the fourth drug controller who signs the final product. But this is the first time in history, I think the first drug controller will be signing the preparation as well as the final product also. So I think a lot of things have changed with the COVID hyperloop. COVID actually connected research with practice, created a hyperloop. Some innovations happen in 17 days, some in 17 hours, some in 17 weeks. Within a year, we had a vaccine. So these are things that will go down in history, because 2020 will be a benchmark, a watershed line for the world to relook into the way every single thing is going to be conducted across the world. And I think it's time for us to relook into the process of bedside to bench and look at how the next generation of surgeon scientists will be created with the Dr. Prhnos. I'm sure Kumresh will have a very interesting perspective in the coming talk. So this is going to be, I think, a very essential thing that we will need to nurture for our colleagues, youngsters, students, at the very beginning itself, that he doesn't need to wait until he becomes a professor to re-question some of the status quos. And so today I'm just going to quickly scan pass on, when do you do research, when do you invent, when do you innovate, and when do you do a jugaad? If you look at the total gross domestic expenditure of R&D, India actually fares among the top 3 in terms of the number of papers published. But if you look at where do we stand in terms of patent filings with regarding to R&D expenditure and personnel, look at where we are. We are way far behind. So this is from a paper that I wrote, and this is under review currently. But trying to understand what happens in India, we say we are so advanced, we are doing so much of work, but why are we here? What actually takes us to be here? And it's a long discussion, but I just want to share a perspective to say, what does it take for us to be the leaders in the globe? But if you look at our productivity for the number of people and this one, it's pretty good, but there's still a lot more that we could achieve. So a lot of the aspects around design health thinking is, how do I find the right problem, like what Duwari said, and how do I get rid of the problem by inventing something relevant? So sometime back when I was sharing a perspective with Government of India, I actually shared that we need to move from make in India to create in India, because a lot of the times we import from China and we create it in India. The essence of the entire philosophy has to be that we don't import it from China or some other country and make it in India, but we have to create it end to end in India. And my current working of goal, where I'm helping both the state and the union government, is to look at conceptualizing the models of create in India, where we create it end to end, and we are not going to depend on any other country for creating or importing any of our products. And this will require a significant change in the perspective of academia to industry collaboration, where research, academia, knowledge, values will connect with markets, economy, and wealth. And this is very, very crucial in the changing days. This has already started to change. And I believe that is something that our youngsters will have as a responsibility, not just to look at what lies with what we can do immediately at hand, but also to dimly look into the distance. And I'm alluding to this paper from Lancet Oncology in November 2017, which talked about cancer moonshot. I'm not going to go into the details of it. 37-page, very nice paper, talked about a lot of perspectives. In fact, after that, the paper that came out from Lancet was, will cancer be the winner in this election of the US? Because Joe Biden himself was the man who funded this entire thing. But there were 5 important things that came out of this message: enabling technologies, immunotherapy, precision medicine, personalized medicine, and big data. And I think these are the technologies that are going to define Health 2.0. A lot of these technologies are going to be game changers for us. And Moni sir already spoke about how adoption of technology logically will actually make a difference, but we cannot shy away from it. From February 2011, when IBM Watson actually won the competition of Jeopardy, a lot has been discussed on AI. And there's a lot more to talk on AI. I'm not going to go into the depths of it, but what I wanted to tell you all is we are currently at narrow artificial intelligence and reactive machine AI with the current robots. And where we are worrying about is super intelligence and self-aware AI coming in. We've already started touching limited memory AI with the current Tesla cars and other things. And I think we are going to move forward. And that's what Stephen Hawking was worried about. When we reach there, what's going to happen? So artificial intelligence for using it for medical records, repetitive jobs, treatment designing, digital consultation, virtual nurses, medical management, drug creation, precision medicine, health monitoring, healthcare systems. We are doing it all right now with stage 1 AI reactive machine, but the next stage is going to be limited memory, theory of mind, and self-aware. And we're going to be reaching there soon than later. For the interest of our audience, this is a very interesting book. I was interacting with Rupa, and she shared this book with me. She had written on Digital Nation about solving technology through the people's problem, written with the chairman of Tata Group. A very thought-provoking idea, which I think the government of India has perceived very seriously. In the same way, if you look at genomics today, we've spoken so much about it from 1956 when Watson and Crick talked about it to Craig Venter talking about the Human Genome Project. I'm not going to go into the depths of all of this, but what I wanted to tell all of you is, you know how many genes we have? We have over 23,000 genes. But look for a second and see how much does one rice grain have? It has basically about 50,000 genes. So for all of us who think that we are God's gift to mankind and what we have contributed, a rice grain seems to be more complicated than us. So what is it that makes us that supreme being in the top of the food chain that we are today claiming ourselves to be? You know, a lot has been spoken about genome and the epigenome and now the microbiome, that we are more of a microbiota than that of a genome. And it is this 10 to 20 million microbial genes that control our 23,000 human genes. Through these entire years, we've had a lot of understanding about metabolomics, proteomics, genomics, microbiomics, epigenomics, and now we are talking about multiomics. And that's going to be the future for oncology, to talk about multiomics, where we connect the dots from genome to microbiome, talking about how all of this is going to play a role. And I again would like to reiterate that the next generation of doctors will have to be surgeon scientists, spend some time in the labs, build the future of oncology. We've been doing some early work. I just wanted to share some papers. This is one of the papers that we jointly did with the University of Chicago, where we developed the ultra-sensitive detection for tumor-specific mutations using liquid biopsy from saliva to detect oral cancer. We've always been doing a biopsy to detect oral cancer. This study showed that we could, just by a swirl of a saliva, using an algorithm of bioinformatics, pick up oral cancer to a fair accuracy between 80 to 90%. The point what I wanted to share was we made a small shift from biopsy to non-invasive saliva. And this is technology based. It's got a long process to go. Like I said, 17 years would be a rough estimate. But what I wanted to share was this is currently published in Cancer. We've made progress. We achieved this. And we slowly make a small baby step in science. Similarly, we've started working on radiomics and radiogenomics. We were able to pick up 79 radiomic features based on a photograph. So imagine if I could, like a photograph, I zoom in, I could zoom in the CT scan, and that CT scan could see the cell and tell me 79 features: intensity, shape, texture, based on just intensity, size, and this one. If 79 features can be picked up and genomic signatures can be predicted. So that's where we are already right now, and we are moving further. So the future would be a pathologist and a radiologist sitting together, and the digital slides would something look like this with all kind of signatures. And this is what we are already done. And so I believe the future is going to be much more exciting. So I've been a part of a lot of innovations. I've got about 18 patents now on various ideas, innovations, theories. And I felt that it was that belief that my mentors, teachers, and governments and friends who supported me through this journey kept encouraging us. So we've actually got a lot of these patents. I'm going to flip through all this. I've invented a drug which recently got a patent granted to some things in blockchain that we are working on, glycolytic pathways that got a patent, to developing a cancer vaccine, which is currently ongoing, to developing an extended reality, which I have now collaborated with Microsoft, to developing robotic retractors, which government of India is supporting us right now with, or an intuitive glove for patients in ICUs. The gist of all of this is we are not constrained by the discipline of rigor. We all work very hard, but by the limits of our purpose to make a difference, and that can be defined sometimes by just our imagination. So I think we also in the line need to look at moving from ambition to purpose somewhere. And we've created this forum called Design Health Thinking now, where I actually help youngsters look at how to design health think and take it up from idea to minimal viable product proof of concept prototype with the support of Government of India. This is a joint initiative that I've been doing with Government of India, where the complexity of creating a startup, business plan, investment, this is not my job. I mean, I really don't understand all of this. I chose biology for a reason because I was poor at economics, and it is better that I acknowledge it earlier. So they've created an ecosystem for me where all of these come together through design health thinking. And we believe now that if opportunity wants to knock the door, you need to build the door. Don't wait for the opening of the door. That was in the early eras. Now you create your own door and enter. And that's what we do here. We actually help you create that door if you believe in it. So this is Maker's Nest for you. You know, I built this on the model of Formula One. If Bura racetrack can be achieved in 1.08 seconds, I think you should be able to fast track your innovation. So I told Government of India, look, if you keep asking that innovator to come after 17 years, I think a generation will pass by. Is there a way we can fast track these innovations? And today we have already launched it. And I'm happy to confidently tell you, 5 years from now, I'll present a better presentation than this to tell you that we will achieve this, you know. So IIM, NSRCL has joined hands with us. I'm closing my slide. I think this is my last slide. I want to leave you all with this thought on Ikigai. I want all of you all to maybe look at Ikigai, what you love and what the world needs is your mission. What the world needs and what you get paid for is vocation. What you get paid for and what you're good at is profession. And what you're good at and what you love is passion. So this makes an Ikigai formula for all of us. And I think each one of us needs to have this circle of Ikigai to understand what is it that I'm doing at this current point in time. Failure, success will keep happening, but I think it's the Ikigai that differentiates us. Thank you very much.
Thank you, Dr. Rao, for your really stimulating as well as thought-provoking talk. And I'm sure your success in this whole domain will stimulate a lot of these young generations who are the great innovators of future.
Thank you, sir.
Thank you.
Thank you for the opportunity.
Yeah, I think with that, I will invite the next speaker, Dr. Kumresh. It's a very, very important and interesting topic. Why I think doctors should lead the innovation. Dr. Kumresh, please.
Yeah, thank you. And can I have the permission to share the screen, please? Can everyone see the screen?
No, I think it is coming. Yeah.
Are you able to see now?
No. No.
Okay.
Yeah, I think now it's coming. Yeah.
Okay.
Just now you can go to PowerPoint mode.
Sure. Good morning, everyone. It's always a tough job to follow a speaker like Vishal. And let me see if I can do some justice to the topic given. In the last few years, I've been donning several hats, and I always, as the previous speaker said, the health tech and healthcare innovations are going to be the future. Days are gone where you can just treat the patients by surgery or by diagnosis. It's all going to be technology. And most of the technologies, they fail because either they don't have a doctor on board or they don't get the idea from the doctor, or they think this is what the doctors need. So off late, I've been giving talks wherever it is saying that, you should have a doctor and doctor should lead. I'm a national mentor for Niti Aayog for their startups. I sit with ISER Pune I work with IITs, triple IITs, and sit on the board for universities. But this is a sad story. There are, as of date, there are close to about 5,000 startups in healthcare as such. But how much have really seen the light of the day? Probably about 3 or 4. And there was a question saying that why do they fail, or why is it that the companies are not taking up? It's because we have to give what is needed for the society, and we just cannot do what we are comfortable with. Doctors, and I've been extremely passionate for the last 3 years. I've been encouraging doctors to get into this space. And as doctors, we already are natural entrepreneurs. Whatever the skill is needed, we have it with us. We have our own clinics, hospitals, diagnostic centers. We do research. These are all needed for an entrepreneur. And the patient is also becoming an informed consumer, wherein he knows what he wants, he knows what's happening. And the rural or the urban divide is kind of disappearing. Even in the rural areas, the people know what is happening and what they should get for the price they pay. And after this government has taken over, they have been pushing for the Startup India or the Make in India initiatives. And we are seeing more and more technology people just getting into the healthcare. And one of the things they say is there is a huge lacunae of doctors in the country. But by giving softwares which help in the OPD, it's not going to help. There needs to be a very huge healthcare reform in the form of devices or diagnostics. And as doctors, we are the cog of the healthcare system, and we own the flow of care. We know what the patient will need or how the patient will benefit. And that's why the doctor should be the center of any innovation or any entrepreneurship program. And this is a sad reality, where we have become more like an e-commerce place, where we have become more like, people can come and purchase us. So most of the hospitals are now taken over by investors, and they tie up with a lot of people. And it's like, who's going to give you the best for the cheapest cost rather than for the highest cost? Look at this. There are sites which mention 1 of 3 medical cases are misdiagnosed. So what's the impression we are giving to the people? Saying that, most of the doctors are money-minded, or that we are greedy, or that we are, not helping the patients. And now we have got such things wherein the startups are saying, get into surgery, we will guide you who's the best doctor, who's the best hospital, where you have the facilities. And the worst part is, for the money guarantee, they say the lowest money has been guaranteed, and which is sad. Worse, when I saw this, I was really boiled. Just look at the unlimited doctor consultation for 1 year. And here we have a site which charges close to about 500, 600. And how much does a doctor get? 50 rupees, which even my plumber will not, do a work for that money, but we doctors are doing it. And, this is the state we are in now. And this needs to change, and it can change only if we all join hands. And, let it be oncology, let it be surgery, or let it be medical practice, whatever it is. One of the things most of the startups or most of the innovators forget is we are under ambit of Consumer Protection Act. And there is a huge difference, because whatever happens, irrespective whether you are involved or not, you are liable. And who's going to be the sufferer? It's going to be the doctor who is going to be suffer, or the healthcare personnel. And if you are going to use any device, whatever it is, let it be digital health, or let it be any equipment, if the outcome is not correct, or the patient is going to suffer, you are liable, not the startup, not the device for which you are used. And that's a funny thing about the law. Now, the previous speakers, especially the first one, the robotics, why it didn't take over even in the US. When that's the case in the US, let's take the case of India. That's why I've been saying, like politics, we should understand healthcare is local. And what do you mean by that? There are different scenarios. There, insurance pays for almost everything. Here, the patients pay out of the pocket. And look at this out of the pocket thing, where they spend. More than 50% is spent on the pharmacy, where the pharmacist acts as a doctor, and he gives the patient the medications, which you cannot get it anywhere. And that's how no, most of the startups in the pharmacy sector are thriving, which is, again, it's going to come back to us. If there is going to be any problem, who needs to face the music? This is an interesting thing, wherein I was called as a consultant for this startup, and they had received a huge amount of funding, close to about a few hundred crores, and this is for the home care. And I'm sure we'll be seeing a lot in the news saying these people have got the funding, these people have got so much funding, but they were not able to succeed. They were not even able to give back the returns, and that's because most of the tech forget that patients do not pay for the services. A case in point, I wrote this paper, and earlier the government was giving billions of dollars of crores of rupees for the cochlear implant surgery. But after 2 or 3 years, they found out it was a huge loss, and the success rate was very, very low. And what was the reason? The patients were not able to travel to go to for their rehab. They were not able to afford even the batteries. They were giving so much, like each and every implant was costing close to about $15,000, and it's gone on the drain. And just imagine if there have been 1,000 or 10,000 patients who have been implanted, it's all gone in the drain. That's because we have to do innovations as per the local market, and we just cannot copy saying that it works in the US, it works in the UK, it will also work here. Again, this other one, telemedicine. I still remember a startup mentioning in the LinkedIn saying that, I'm got into this, I got close to about 10 crore funding, getting into telemedicine. I have about 100 doctors. I just wrote him, very good, congratulations. But are your doctors aware of the legalities? Are your doctors aware that they are liable for whatever and it's not you? As per the new rule of the IT Act of 2020, anyone who's going to get into this space, they have to register themselves and they have to inform the doctor is liable. No one does it. Now look, even during the COVID, the Karnataka government came out with a rule saying that we are not going to approve of the teleconsultations. So if that is the case, how are you going to work around this legal thing, which only a doctor will know? I'm not sure how many of you are aware of this, the Digital or the Disha Act. As per this, it's a very funny thing. About 6 months back, one of the major corporate hospitals said we are tied up with such and such company, and we are going to come out with unique things in cardiology and this. So I wrote to the CEO, please tell your director that as per this act, they should have got the permission, and yeah, we got the permission. No, again, if your data is going to be shared or if your patient's data is going to be shared, it is you who's responsible, not the startup or not the hospital. Now, all these I'm telling negativities because I'm going to tell the positivity later. This is again, some people are saying about artificial intelligence and machine learning and how things are not working out. You have to know where to use the technology, and that's where the success lies. Like in this, I still remember going to one IIT Madras, and I was speaking to one of the professors there where we wanted to do a project, and we are doing some 2-3 projects. And one of the things he was interested was doing thermal scanning for breast. I said, it's not going to work. He said, no, there's already a startup, they're very successful, you're going to do it. I said, do it. After 3 years, he has realized, because not only the FDA, even the Indian Breast Association have said that such things cannot be used even for screening or even as a tool of diagnosis. So what's happened to the funding? And if a doctor, if I'm going to do it, I cannot, because then I'm going against the rule of the land. So this is what it is. Technology is good, but you have to know how to play around the system, which as a doctor, you will know which works. Same thing with IBM Watson. They are close to about, pumped in close to about $100 million. There are so many hospitals saying we are tied up. And what has happened? They shut shop. And I can talk about so many startups which got crores and crores of rupees, which I have seen in most of the newspapers. They all have shut shop. One of the reasons why I think this has failed is you cannot replace a doctor. You cannot say technology is going to replace. How can a technology replace a doctor? It's not possible. And when you're going to say it, what you're going to do, you're going to make the specialist be agonistic or antagonistic to your technology. If someone is going to say, oh, Kumaresh, I'm going to come out with this, please help me out, it's going to replace you. You can't expect me to help them out. And, you cannot replace. Yes, we are into AI, I'll show you in the next few things. We are into AI in oncology. We are into AI in ophthalmology. We are into AI in chronic diseases. But I do know the doctors cannot be replaced. We work in such a way that it helps a doctor and not replace them. And this is one of the things which I did before I take any topic or any project. It will take about 3 months for me to really get into it. I do the studies, I find out what is what, and then I tie up with the institutions of repute. I don't go to any other institution. I work only with IITs, IIITs, BITS, ICER, and over here, either the AIMS or the government colleges. That's because that's where you get solid data. And when a product is going to come out, it needs to have the respect of the society, and people should be willing to use it. And in this case, we are tied up with the Railway Referral Hospital in Perambur, where Dr. Suresh was the director of ophthalmology, and we wanted to go in to see how we can work it out. And just imagine, we had given close to about 15,000 images, and all we could achieve was the machine was able to localize the optic disc. So you can imagine why AI is taking such a long time, and why AI is not able to get to the extent where we wanted it, because it needs enormous data. And not only enormous data, the data needs to be good. Like, you would have heard about Google talking, but Google was not successful in India except for 1 or 2 centers. Why? When you're going to do a study, you use such wonderful camera and you take the pictures, but such camera will not be available anywhere and everywhere. And if I need to incorporate it in my practice, I need to spend a huge amount of money, which is going to be a waste. So, technology is very good. You need to know, just like this, when most of startups come and say, we are going to help you with your practice, we are going to help you with your patient care and all that. Against my wish, one of my very close friend, he wanted me to help him out with one of the digital health tech. I said, okay. And believe me, my practice, which gets over by 9:30, was going on till about 12:30, 1 a.m. I said, this is not going to work. And I'm a guy who's extremely vocal. When I see people talking about all this, I say this is the most misused word. Digital health and artificial intelligence are the most misused word being used by the technologists, and doctors are not aware. They are just weighed by these words, and they say, oh, wow, I'm involved in AI, I'm involved in digital health. But we need to know what is there in AI, what is this? Now, coming to the major question, in spite of all these fallacies and in spite of all such difficulties, why should a doctor who has spent more than 15 years of his prime time get involved into entrepreneurship and innovation? Because I believe the future is only in that. And just look at the perception. There was a survey in LinkedIn where a person had put, should IITians should do this and all that, and everyone is saying, wow, are we living in a democracy or an autocratic? How can you ask IITs? IITs are the ones who are giving us name, who are bringing us money. And some even went and say subsidized education is given to make it affordable to all students. So that means what? If a doctor was to do that, it's service. When you're going to do it, oh, you're money minded. But when IIT does it, oh yes, they are building that economy. And that's a perception. And until otherwise, we also change our mindset and do what the public want, we are just going to be one of the species which has become extinct. And other thing is, as a doctor, whatever you come out, that's going to have a huge impact on the public, because let it be all the negative fallacies, the public still has some amount of respect for the doctors. And when you innovate your own product, they accept, and they know, being a scientific person, you have done scientific things. This has helped us even to enter into 4 international countries, and we are bidding for their governments. And the same thing here. This is a question which I ask. Can you disrupt? Everyone says disruptive technology, but how can you disrupt something when you cannot disrupt the people who are using it? This is a thing where we came out with our video endoscope. This was one of the first things we got in. And one of the first things I did was gave it to my friend in a government hospital, asked them to use it. And when they used it, they said, these are the things which is wrong. Immediately we redesigned it. And then we also got something for the difficult intubations. And we use the same Macintosh blade. So, it was ease of use, which made them to go on and use it. And during the corona, the same thing. We have got, again, all these are patent published, protected. Look at this. This is our Wi-Fi or a remote thing, wherein when they wanted to use it for students to viewing, we came out with this model. And next is for the remote. This is what we have to do. There, the procedure was being done in Chennai, and I'm sitting in Bangalore, and this is in real time. Okay, and this is in real time. So this is what technology should be. Again, with regard to the UV, we came out with and these are not for Corona. This was long before Corona. This was the first model. When we got all the inputs, we changed. And people were saying it's very difficult. That's very difficult to enter into India because we don't have any regulatory mechanism in place. So what we did, we followed the US regulatory thing, both for all our devices. We found out what works, what doesn't work. And when people are coming out, we were getting all the clearances needed. And that was what it enabled us to penetrate the markets much more faster. And being a doctor and a clinician, I knew that one thing will not fit all. We came out with so many models, right from the airlines to your clinics, to hotels, to hospitals, to ICU. We tested, and here you can see if I can prove that there is nothing in the AC vent or in the BP, then this. So saying that there was a question saying it's very difficult to penetrate the market. No, you need to know what to do, how to do. I'm working on all this where we are working with remote monitoring for, it's remote monitoring in the sense.
Dr. Kumresh, can you please sum up in a minute? Because
sure, I'm finished. This is the last slide.
Yes.
So, I'm working with the remote monitoring. I don't work with remote ICU because that's not going to work. And we are working with anaphylaxis identifier for chemotherapy. We are working with artificial intelligence for breast cancer, for oral cancer, coming out with chronic diseases. And I'm working with all these institutions getting into 3D bioprinting. So now it's time for you to decide whether you want to still remain a doctor or you want to get into innovation where the paradigm shift is doing. I am still have my own practice. I still practice. In spite of that, I also play a role in the entrepreneurship and the innovation cycle. Thank you.
Thank you, Dr. Kumarish. I think we have quite exceeded our time. So, Dr. Iyer, you have something to comment? Or otherwise, I think it's excellent session for innovation, and with all these talks are excellent, thought-provoking, and with a note of the both sides, I think there is a lot of scope to go ahead, and I'm sure in India ecosystems are improving very fast. We are also trying to develop the regulatory science research as well as regulatory science center in India. So overall, I think in near future, India can become a really big hub of the technology development, both incremental as well as disruptive. So with that, I'd like to thank the organizer and as well as all the speakers in this session for a very successful session on innovation. Thank you. Now I hand over to the coordinator.
Dr. Balaji?
Yes, sir, I am in. Can you hear
Yes,
me?
we still have 20 minutes, so you can check your slides if you want.
Yeah, I will just try and do the checking.
Just hold on, sir. We will give you the rights to share.
Yeah.
Please wait for 2-3 minutes, sir. Then you can start sharing your screen. You can check the slides.
Yes, madam, definitely. Oh, 20 minutes.
Dr. Balaji, you have checked your slides, sir? Hello, Dr. Balaji.
Yes, shall I check now?
You have not checked it. If you have, you can please check and then
Yes.
we'll start sharing our screen. So you have to remove your sharing.
Yeah.
Okay, so please check and then we'll do our things. Sir.
Yeah, sure.
I have a video to show. Can I just check once the video? I'm Dr. Abhishek this side.
Yes, sir. Once Dr. Balaji is over with his checking, then you can do it, sir.
Thank you so much.
Madam, can you see my slides?
Yes, sir.
Can you see my videos?
Yes, sir.
Thanks, madam. I have checked, madam. You can tell other faculty to check also. No any issues. Thank you.
Thank you, sir.
I'm going to try to check my video is visible or not. Can you just confirm, please?
Yes, sir.
It's visible? Can you see the video?
Sir, yeah, it's playing, sir. We are able to see it.
Thank you so much.
Dr. Abhishek, can you? Yeah. Dr. Abhishek?
Yeah, hi.
Yeah. It's my lecture is the first one, 1:30.
Okay.
I just wanted to see the program. It is 1:30, na?
Yeah, it's 1:21. Yeah, yours is 1 second. Yeah, first is Arun and then Jayakumar Menon. Then it's you, Rakesh Srivastava.
So that will be at,
I think around 14 minutes. So around.
I think mine was the first. I think mine was the first one. I think.
Actually, I'm not the chairperson of the session. I'm myself a speaker here.
Okay.
Rakesh sir, hi Akshay here, sir.
Hi, Akshay.
Hi.
Hello, Rakesh. Vidyadharan.
Yeah, please.
I think you may be going in third, sir. The order is Mr. Arun Balaji, Dr. Jayakumar Menon, and I think then Dr. Rakesh Srivastava, and then Abhishek, and then Dr. Sapna. I think that's the order. There is a little bit of difference in time here. They're saying 1:30. In the program, it says in the program also it says 1:30 only, sir. But I think it's 15 minutes. 15 minutes in the top. That's the information we have also got.
Yeah, it's 15 minutes for each speaker, sir.
Okay, thank you.
No, if all are ready, maybe we can start. Dr. Vidyadharan, if
yes,
the first speaker is there and the chairpersons are there.
Yes, madam.
We can go ahead, ma'am.
Start. Maybe we can.
We can.
We'll
We
get
save
some
time also.
more
Yeah.
time.
Sure, ma'am.
We can take starting the slide
now
of chairperson and speakers.
Yeah.
Akshay, would you want?
Chairpersons are there, Dr. Vidyadharan, Dr. Akshay. Dr. Akshay is there?
Yeah, please.
Yeah, madam.
Is
Hi, Akshay is here.
We'll start now. We'll start.
Akshay, then you go ahead, Akshay.
Yeah.
Okay.
Good afternoon.
I'll just welcome Dr. Akshay. He's a senior consultant and director of the Head and Neck Oncology Site Care Hospital, Bangalore, and Dr. Vidyadharan, director and consultant head and neck surgeon, the Head and Neck Center and Hospital, Chennai. Welcome both of you, the chairpersons, for sharing this session. Over to you.
Good afternoon, madam. At the outset, we would like to thank you for introducing us and really congratulate you for a wonderful academic feast which we had over the last couple of days. So going forward, we are in the end of a session. We have 5 talks lined up with technology incorporating into head and neck surgery. And to start with the first 3 topics pertaining to larynx, then followed by a thyroid, and then the advanced radiation technology of proton. So first up, I would like to invite the first speaker, Mr. Arun Balaji, who is an accomplished speech and swallowing specialist. He currently leads the speech and swallowing team at Tata Memorial Hospital, Mumbai. He is a very accomplished clinician as well as academician with multiple involvement in clinical trials pertaining to swallowing research, and also into teaching with faculty as well as a mentor for many young swallowing and speech pathologists and young ENT doctors. So over to Arun Balaji for his presentation on fees. Welcome, Mr. Arun Balaji, and you can please go ahead.
Thank you so much, sir. I will be sharing my slides soon. Can you all see my slides, sir?
Yeah, we can see your. Make it full screen and you can go ahead.
Yes, sir. Is it okay?
That's good.
Yes, please.
Good afternoon to everyone. I would like to thank Fhno for giving this great opportunity. Today, I'll be focusing on flexible endoscopic evaluation swallowing in head and neck cancer. My sincere thanks to my eminent head and neck surgeons, my speech language therapy colleagues, my international speech language therapist colleagues who are guiding me constantly. As we know, head and neck cancer has a huge functional impacts and affects quality of life significantly. based on this research, they have said that swallowing is one of the topmost priorities for the patient before treatment and till 12 months after treatment. So fiber optic endoscopic evaluation of swallowing is also called as flexible endoscopic evaluation, developed by Professor Susan Langmore in 1988. It is done transnasally to evaluate pharyngeal swallowing function. So this is the usual feast setup. We can do with normal food, with food coloring. And this is one of the aerosol generating procedures. We need to use PPEs in view of COVID-19. And other important objective swallowing evaluations of video fluoroscopy. This can be done by speech language therapy and radiology jointly. And I will be focusing on fees this presentation. With the fees, we can able to evaluate various things, such as important key findings or pharyngeal secretions, penetration, aspiration, and where it is happening at the level of airway, whether it is penetration, aspiration, and due to penetration, aspiration, we can see the response to it, whether patient is having cough or there is no any cough. We can also see, we can also visualize the residue, spillage, bolus pathway. A residue is one of the surrogate marker of pharyngeal, maybe the pharyngeal weakness. We need to find out where is the location of the residue. It can be a residue in the vallecula or residue in the piriform sinus. Based on that, we need to infer the information through fees that can be due to base of impaired base of tongue retraction and impaired hyolaryngeal excursion. One of the major purpose of a fees is evaluation as well as intervention in pharyngeal swallowing function. And during this procedure, we have to use a few important outcome measurements. One of the majorly used scale is penetration aspiration scale, but we can use other scales to get a lot of information by doing this fees procedure. One of the important scale is the pharyngeal secretion scale, which is the recently developed by New Zealand secretion scale. And next thing is residue scale, yawl residue scale. And we can also evaluate edema due to post-radiation. And recently developed scale is digest fees. So these scales are very, very essential, and it gives a lot of information. And with digest fees, we can able to categorize the severity of the pharyngeal function. And this is another paper by Italian group published in 2019. Penetration aspiration scale can be used in fees as well as a video fluoroscopy. But there will be a lot of challenges using penetration aspiration scale in partial laryngectomies. We are all talking about partial laryngectomies in these 2 days in our conferences. But how are we going to evaluate partial laryngectomy swallowing? We can use fees, and this is one of the great tool. They have modified penetration aspiration scale majorly for this population as well. And fees has been used more than 2 decades in head and neck cancer, right from the 2000 and 2010. And even in India, the usage of fees is increasing gradually. And now we are recognizing fees as one of very important tool in our head and neck cancer evaluation armamentarium. Now, over the period of 10 minutes, I would like to show various videos in terms of pharyngeal swallowing function in normal fees as well as fees in head and neck cancer. This is the fees in oral cancer patient. It is a functional swallow, and you can see there is no residue before and then anything before swallowing, and he could swallow very well without any kind of a residue. This is a normal swallow that we can able to visualize endoscopy. The next video is carcinoma of larynx post-radiation. You can see how the epiglottic retroflexion is happening. Such a great tool to evaluate epiglottic retroflexion, and it gives a 3D panoramic view, and it gives a very good feedback. And we can able to evaluate aspiration, whether patient is aspirating or not in this fees procedure very well. And I would like to show aspiration in post-chemo radiation after 1 year. This is a gentleman, carcinoma of piriform sinus, underwent chemoradiation. You can see severe aspiration after 1 year. This is one of the dysfunctional larynx. The patient is having aspiration, severe aspiration, even after 1 year of treatment. The next thing is 4 weeks after treatment, 4 weeks after radiation therapy, how FEES is helping us and making sure that patient is not aspirating and he doesn't require any kind of a feeding tube. And we can see there is a little bit about laryngeal edema in this patient as well. And we are talking about epiglotectomy, how the patient is swallowing after epiglotectomy. I would like to show you one FEES video after epiglotectomy. It is a 1 year after epiglotectomy. See how the patient is swallowing. First, the patient is eating a banana. He is chewing it very well. He is swallowing. There's a little bit of penetration. He could able to eject it out very well with cough. This is how we can evaluate FEES in this population group, post-epiglotectomy, and the patient is now drinking a thin liquid. And see how epiglottis is coming closer. Very good laryngeal adduction is happening, and there is a slight amount of penetration is happening, and patient could able to clear it out with very good effective cough. These are very, very essential information in terms of evaluation as well as rehabilitation by using this procedure in head and neck cancer. And the next, I would like to show you a case presentation on epiglottis, carcinoma of epiglottis. This gentleman, he was diagnosed as carcinoma of epiglottis. You can see the carcinoma in the laryngeal surface of the epiglottis. Everything is fine. There is no any secretion. Bilateral cord mobility is good. Our surgical team performed a transforaminal laser microsurgery for removal of this epiglottis. And this is the acute FEES after epiglottic laser surgery. There is no epiglottis. And we can see there is the changes in the mucosa due to acute period. There is a good amount of laryngeal adduction is happening for this patient, and we will see how the patient is swallowing without epiglottis. Now patient is drinking a thin liquid. There is a good laryngeal adduction is happening during swallow, and there is no any aspiration. And FEES is a very valuable tool in evaluating head and neck cancer dysphagia. And I would like to focus on FEES in a partial laryngectomy. This is a little hard. Definitely, we know that FEES partial laryngectomy patients have significant swallowing dysfunction in the acute period. With active swallowing rehabilitation, definitely these patients we can rehabilitate very well. This is the endoscopic image of one of our patient. This after 3 to 4 years of treatment. This gentleman underwent supracortical partial laryngectomy, and we will see the long-term swallowing outcome. It's a very good, this patient, he had a severe swallowing dysfunction. He was having severe dysphagia with feeding tube as well as a tracheostomy tube for almost 4 months of post-treatment. With the active swallowing therapy and rehabilitation, he could swallow very well. See how arytenoid is coming together and it's touching the base of tongue. This will tell us how the patient is swallowing safely, and it FEES guide us to evaluate as well as do the intervention. And not all the patients we can perform FEES. In this endoscopic image, we can see we cannot able to visualize the endolarynx. In such patients, we have to use the video fluoroscopy. See this video fluoroscopy. How this patient swallowing. If you do FEES in this patient, we cannot able to evaluate well. So in such patients, we have to select video fluoroscopy. Sometimes we cannot able to use FEES in all the patients. So I would like to discuss one more patient. So as I said earlier, if you are unable to visualize the endolarynx, we cannot, we should not use a FEES. We need to use video fluoroscopy. See this endoscopy. This is a post-crack cord. The patient is having unilateral vocal cord palsy, and this patient is having a New Zealand secretion score rating of 6. And we have to think very wisely whether fees only is essential or we need to do any other further investigation. We performed a video fluoroscopy for this patient, and we can see a severe aspiration. So these patients are not good for apparent organ preservation. The best surgical treatment is total laryngectomy with gastric pull-up. So we have a question whether fees or video fluoroscopy. If you see, a fees is a very sensitive, and it is accessibility is good. There's a dynamic physiology that we need to find out. When you think about dynamic physiology, video fluoroscopy tops than fees. Efficiency, accessibility, fees is more accessible, whereas a video fluoroscopy, we have to wait for radiological suit, and we may wait for 1 week or 10 days to getting the appointment for a video fluoroscopy. And for a biofeedback training, fees is a very good tool. But remember one thing, Professor Susan Langmore and even our clinical experience says that these two procedures are not rival. They are complementary to each other. So we have to select the procedures wisely, and fees has a great space in our head and neck cancer evaluation and treatment, and as well as a rehabilitation. Thank you so much. If you have any questions or anything, definitely I would happy to answer.
Thank you, Arun. There was a lovely talk and very detailed talk on fees. And you nicely explained the concepts of fees with clear videos. So it was very nice. We don't have any questions in the chat box at present, but maybe towards the end of the session, if we do, questions do come up, I'll just ask you.
Sure, sir. Sure, sir. Thank you so much.
So please stay till the end of the session.
Yes, definitely. Okay. Thank you so much.
So we'll now go on to the next presenter. Can you put the profile slide of Dr. Jayakumar Menon, please? Okay. Next speaker is Dr. Jayakumar Menon. He will be talking on stroboscopy. He is the director of Dr. Jayakumar's laryngology group and also the head of Department of Laryngology in the PRS Hospital at Trivandrum and Aster Medicity in Cochin. He's also the head of the Division of Diglotology at Amrita Institute of Medical Sciences in Cochin, and also honorary consultant in laryngology at STIMST Trivandrum. He was the first exclusive laryngologist in the country, and is founder, vice president, and the past president of Association of Fhno Surgeons of India. And he's edited one textbook on swallowing disorders in head and neck cancer, along with many numerous chapters in other laryngology textbooks. He's also described, and he's famously described the clinical sign to diagnose adductor spasmodic dysphonia. This is mainly a neurological issue with the voice box. Jayakumar, sir, if you're online, please do share your slides. Thank you.
Thanks, Vidyadharan. Let me start. Yeah. I cannot share now. Am I? Hello?
Yes, sir.
I find that share button is gone now.
Ms. Shalu, do you want, sir, would you want to log off and then log in again? Try it again?
So we can just try one more time.
What should I do? Just now it was there, but then it went.
Sir, just refresh and try one more time, sir.
Yeah, okay. You can see my slide?
Yes, sir, we can see your slide.
Thank you. Thank you, Vidyadharan, and good afternoon, everybody. End of another hectic day. Yeah, I was coming from another conference. That's why I got late. Okay, so we are going to talk about stroboscopy in glottic malignancy. And generally, stroboscopy is supposed to be an important equipment of the laryngologist rather than the head and neck surgeon. And many people may not be very familiar with it. So what we are going to look here is that how important is stroboscope? Is that very important, or is it indispensable? All these things, and what are its advantages? What are its loopholes or pitfalls? Now, stroboscopy is based on the concept of Talbot's law. It's basically an optical illusion. I'm not going to the very big details of that because then the time will not be there. It's sort of an optical illusion. But the important thing is that it is truly representative. We all know that the vocal cord vibrate at a very high frequency. The males, it will be somewhere around 100, 120 or up to 150, and females it can be anything from 180 to 250 or even more. So when vocal cord is vibrating at such a rate, you can't actually see the vocal cord vibration individually. So the ideal way would have been a high-speed camera, which is available now, right about 8,000 frames per second. But then that is a big issue. You can't use that. If you use a high-speed camera for 1 minute, and when you see in slow motion, half of your hard disk will be gone, and it will take hours to see that 1 minute in detail. So that's a technical issue. You cannot use that. So then stroboscopy remains the best possible alternative. It is an optical illusion. If a person has got 120 frequency of the vocal cord, that means the vocal cord vibrate 120 times in a second. Instead of seeing it as a slow motion, what stroboscopy does is that it takes consequent part of each vocal cord, each of this vibration, 120 vibrations. So it will take the first part of 1 by 120th part of the first vibration, the second part of the second vibration, third part, and so on. And finally, all these are merged together based on the concept of Talbot's law, the persistence of vision. So you get a single wave in the time of 120 wave, or if it is female in the time of 250 wave. But what is important is that it is truly representative. So even though it is an optical illusion, it actually gives the idea of the concept of vocal cord vibration, more specifically Rengge space vibration. In the universe, everything vibrates. So in the body also everything vibrates. When you produce the sound, not only the vocal cord vibrate, directinoids, the epiglottis, the larynx, the skeleton, the tongue, everything vibrates. But stroboscopy will pick up only the vocal cord vibration because it is connected to that particular frequency. So other laryngeal vibration will not be sensed in a way that is good. So this is just to highlight the concept of Talbot's law.
Every second. It's like a flipbook. As I flip through here, you can see that each drawing is a little different than the last one. And then as I flip through at speed, the illusion of movement is created. Pixar really wanted to shift.
So that's the optical illusion. So there are so many pages. From out of the pages, one small segment of each page was taken and it was merged together to give a single picture. So if you run fast, you get a faster wave. If you run slow, you get a slower wave. That's the concept of stroboscopy. Now, stroboscope is compatible with rigid laryngoscope, flexible laryngoscope. If you want the modern chip-on-tip laryngoscope, everything. It can be even connected to, if needed, you can even be connected to a indirect mirror. That is the advantage of this equipment. So it's not a scope really, it's actually a technology. So you can connect the strobe effect to any of the scopes available, which is there to visualize the larynx. That's the concept. So strobe is the technique of visualizing the voice box vibration. You can connect it to anything you want. Now, Rengge space is the key for the vocal cord vibration. You all know that. The Rengge space, so if you take the cross structure of the vocal cord, this is the muscle, that is a thyroarytenoid with the vocalis, and this is the mucosa. In between, there is something known as the lamina propria. And lamina propria has got 3 layers. The superficial layer, which has got the loose areolar type of tissue, and the deeper elastic and collagenous layer. The deeper 2 layers fuse to form the vocal ligament, while the superficial layer covered with the squamous epithelium contributes to the lamina propria, to the Rengge space. And it is the Rengge space which actually is responsible for the vocal cord vibration. One important prerequisite for a good vibration is that it has to be homogeneous. So if there is something unusual, the consistency is something different, then the vocal fold vibration will be very different. So when Rengge space is heterogeneous, affected area will appear as adynamic. Adynamic means no mucosal wave. Again, mind you, that's an optical illusion. It is vibrating. Everything is vibrating. But since it is not connected to the vibrating frequency of the vocal fold Renghi space, you will not perceive it. The strobe cannot show it. So what are the things? It can be benign, it can be malignant. The benign conditions like sulcus vocalis or scar, cyst, granuloma. We will just see few of them. This is a scar. Sorry, this is actually not a scar. This is a granuloma. This is really a granuloma here. You can see this is, they turned out to be a tuberculosis. The right vocal cord is vibrating normally. The granuloma is not vibrating well. This is a cyst. Here you can see on the left vocal cord, and cyst won't vibrate or won't show vibration. It is vibrating, but since the frequency is far away from that of Renghi space, strobe won't pick it up. So watch here, the normal mucosal wave on either in front and behind the cyst, there will be normal vibration, but cyst won't be vibrating. Oh, sorry, this is actually a repetition. I think instead of sulcus, I put granuloma at both places. Sorry. Now, in cancer, malignancy also can produce. So what is the role of stroboscopy in glottic cancer? Early diagnosis, because that will actually affect the mucosal wave. NBI will definitely add on to it, and I am sure that you are going to get a very informative lecture from Rakesh soon, after my lecture. So you can see that this is the that's a pure flexible laryngoscopy. No mucosal wave or anything you are seeing. That's just adduction and abduction. But if you do stroboscopy, you will see that the mucosal waves are absent in this area. So that's a mucosal wave here. This is a mucosal wave. But this area, it is completely absent. Anterior, 2/3 of both vocal cord is not there. Here you can see the mucosal wave. The same case with the NBI will give more information. Of course, the Rakesh will be talking about that, so I'm not going into that. So NBI will add on to it, especially in cancer case, how to go about what should be the surgery. Now, what is the role of stroboscopy in glottic carcinoma? Assessing the extent of submucosal infiltration. That's very important because NBI is going to tell that how much is the mucosa is affected. If there is infiltration into the Renghi space at more distal level or more beyond the periphery of the mucosal lesion, then strobe is going to pick up that particular lesion. So it will actually help you to plan the endoscopic laser excision. Here you watch a lady with a globular mass in the right vocal cord. She's not a smoker, but see, they quite a big mass and hardly any mucosal wave here. So it is entirely gone there. So you can always assess the extent of the submucosal invasion of the lesion, how much the lesion has gone. Then, of course, for post-treatment follow-up. So to diagnose early lesion, to plan surgery, how much you exercise, and for post-treatment follow-up. Post-radiotherapy, post-surgery. But what is important when you are doing post-treatment assessment, you shouldn't depend just on one finding, one scopy, because many times mucosal wave may not be there. It is a serial scopy. When you do after 1 month, is it getting worse? That is the clue, rather than one scopy. Just do a one scopy and there is no mucosal wave after radiation or surgery. Don't think that that is going to be malignancy. It need not be. But when you are doing a serial scopy at 4 weeks interval, you can actually identify that. Watch this patient. This is a post-radiation case, malignancy. Doing the scopy, now the mucosal waves are perfect. This is another case. Here it is different. You can see some evidence of adynamic segment. This is actually early recurrence. Even though you are seeing mucosal wave on both sides, you can see on the right middle chord, there is some irregularity and there is asynchrony of the mucosal wave. It doesn't correspond to the closing and opening phase of the other vocal cords mucosal wave. Then, of course, there is limitation in post-surgical cases, especially if the voice is too weak, then it is very difficult to assess. If there is no mucosal vibration, no enough air blast, even a normal Renge space won't actually produce sound. This was a rare case who had an salivary gland tumor of the vocal cord, which was excised, laser excised. Right now, no lesion. But because there is a big phonatory gap, the air blast is not good enough and the mucosal wave is not very great. But there is some mucosal wave anyhow. So that was on the left vocal cord, not very much mucosal wave. This is another case who underwent a vertical partial laryngectomy elsewhere. There is a big gap and there is the missing vocal cord on the middle third of the vocal cord. No phonatory air blast is there, so practically no mucosal wave. So that's a difficulty, that's a pitfall. Just because there is no mucosal wave, you can't say that there is no growth. It is actually growth. It is because there is not enough expiratory blast is there. You see that only this much. This is a vocal process, and here entire it is scar. There is no vocal cord at all in that part. So that is the problem with this kind of cases. Stroboscopy versus NBA in glottic carcinoma, complementary rather than contradictory. But NBA is certainly more useful in diagnosis and planning. Like this case here, you can see that the anterior commissure, there is growth on both vocal cord here. NBA will actually give much better, clearer picture and more signs which suggest possibility of malignancy. So that is all I have to tell about stroboscopy in this limited period. So remembering Ortel, who described this instrument much ahead of his time. Thank you all.
Thank you, Jayakumar sir, for the wonderful explanation about stroboscopy and its application. So I just had one question, sir. So you mentioned that the strobe is mainly for assessment of the depth. And in terms of routine evaluation of laryngeal cancer, and we already mentioned it as well. So that along with flexible endoscopy, NBI adds value more in the evaluation than a strobe, and it of course add complementary information to that. In terms of post-therapy, post-surgical evaluation, does stroboscopy give some information in therapies, a post-laser excision of the vocal cord?
Yeah, that you cannot really uniformly tell that, because some patients differ, because some patient will develop scar. So what stroboscopy is going to say is only whether the mucosal wave is there. That means whether it is suggesting the Renge space, integrity of the Renge space. But sometimes it may be due to the recurrence, sometimes it may be due to the scar of the treatment, either with the surgery or with the radiotherapy. That is why I specifically told that sometimes just one visualization is not good enough to diagnose. So you may have to keep the patient on regular follow-up, means very frequent follow-up, maybe 3-4 weeks later. So a serial stroboscopy might give you the clue. And especially when coupled with the knowledge, where exactly was the tumor, what was the laser excision done, or what was the radiotherapy done. If you know the previous condition also, then you will have a better idea.
So thank you very much for the wonderful presentation.
Thank you.
Yeah. Could we have the introductory slide of Rakesh sir? So after stroboscopy, we have the next topic on narrowband imaging, and I would like to introduce Dr. Rakesh Srivatsa, who has done a lot of work on narrowband imaging. He is the consultant laryngologist at Sushrita Institute of Plastic Surgery and Super Specialty, Lucknow. He is associated with numerous laryngology associations such as Association of Otolaryngologists of India, Laryngology and Voice Association of India, and he has his special interest in laryngology, where he has worked extensively on narrowband imaging, and he has also authored a book exclusively on the atlas on narrowband imaging in upper aerodigestive tract lesion. He's a mentor for many of us, including me. We welcome Dr. Rakesh Srivatsa.
Thank you, Dr. Akshay and Dr. Vidadharan for inviting me for this Fhno conference to share my experience on neurotechnology, that is contrast image enhancement technology, which can early detect cancer of upper aerodigestive tract. So can you see the slides?
No,
Hello?
sir. No.
Cannot see the slide. Check it again. Now?
Yeah, we can see it. Please make it full screen, sir.
Yeah. So the journey started from early 90s when it was studied in Japan by Olympus, and it involved a 10-year of extensive work on image enhancement using narrowband, removing the red light of a RGB, that is white light endoscopy, and introducing it into contrast image enhancement. So it was later on, it came in gastroenterology first, and later on it came in ENT practice for diagnosing laryngeal cancer, and then now into all upper airway diseases. Now we are using it extensively for diagnosing non-malignant lesion using NBI and ruling out malignant looking lesion, which are benign lesions. So now the application has extended from technology and with all research which is involved into it. Now it is time that has come up with the artificial intelligence. So like in all specialty, NBI has gone to AI, and in due course of time, maybe within 2 years time, we'll see AI in NBI. And few instrumentation, newer attachments are coming up with the NBI that will make our job very easy, and we'll have a more data on depth of tumor also. So the concept of NBI is basically, you all know, it is composed of white light, red, blue, and green. What NBI does is it removes the red light, and we use only the blue and the green light. So blue light on reflection to the mucosal capillaries give a brown color, and with a submucosal reflection, it gives a cyan color. So on that basis, we decide about what are the type of lesion and how we have to interpret that lesion. So my presentation will go from here to the interpretation of NBI and various classification, and then I'll cover up the extended application of NBI in my 10 minutes time. Sorry.
Hello, Rakesh sir.
Yeah, something has happened to my. Can you see that?
Yeah, we can see the NBI slide. Yeah.
Yeah, sorry, something has happened. So why we need an NBI? NBI because we were not able to detect a very early lesion. So this contrast image enhancement technology has come up. So coming to first to the vascular pattern of normal vocal folds, we all know the capillaries, they run in superficial lamina propria, as Dr. Jayakumar Menon has told us about it. And our region of interest is basically the mucosal capillaries and the submucosal capillaries. And the capillaries, they run in a anterior to posterior or posterior to anterior direction. And there are few capillaries which come out from the ventricular side and it supplies the vocal folds. And there are few capillaries which come up from the muscular region and it supplies the superficial lamina propria. So there are few capillaries which comes up from the ventricular sides. And depending on the new angiogenesis, the new vascularization of the vocal fold, so ELS, that European Laryngologic Society, has come up with a classification which describes the longitudinal vascular changes and the vertical changes which are seen in the capillaries. So these are the abnormal changes which has been noticed, and they are diagnostic of pathological pathology which is underlying that particular lesion. So it may be a dilated vessel, it may be a tortuous capillaries, it may be convoluted, there may be increase in the number of capillaries. So all these areas we have to focus it when we are looking at the lesion. And the best way to look at the lesion is we have to go as close to the lesion. So best to use a chip-on-tip camera using both the modes, that is white light endoscopy, and then shifting it to the narrowband imaging. Then only we can assess these smaller and vital details of it. So the tricks of NBI is also there, and there are few changes which are very important. That is a perpendicular vascular changes. It may be a large vessel loop, dot-like vessel loops, or worm-like vessels. Any change in the perpendicular vascular changes are indicative of early changes which are indicated of either dysplasia starting from carcinoma in situ going up to the squamous cell carcinoma. So any suspicious changes which you see on a three-dimensional image, once you go as close to the vocal fold, you can suspect that this patient is having malignancy or early malignant changes which are coming up. So on that, a large vessel loop, dot-like vessel, or a worm-like structures that I will show in my further slides. So our area of interest is intrapapillary capillary loops, which are the end capillaries, and these are a very small capillaries of 7 to 10 microns. And using this 4K technology with NBI has made things more clearer, and pictures is vital for assessment of patients. So the first classification, which has come up in 2011 by Ni et al., it generated a clear-cut description of various types of lesion. Type 1 and type 2 are basically the widening of the capillaries, are indicative of inflammatory lesion, and there is a breakage of capillaries in type 3, which are indicative of dysplasias. And we cannot define it exactly that when it has gone from mild, moderate, or severe type of dysplasia. But as far as this classification goes, up to type 4, it is moderate dysplasia. Then type 5A is carcinoma in situ, and type 5B is that is worm-like structure, is squamous cell carcinoma, and type 5C is invasive carcinoma. So on looking at these lesions, we can define it that IPCL pattern type 5A or type 4 or type 3, like that. So for a documentary purpose or for classification purpose, we can use it for to do a further research or further studies into such type of lesions. So these are all the type pattern 1 and pattern 2, that is enlargement of oblique and arborescent vessels indicated of laryngitis, that is benign disease, and then squamous cell carcinoma, mild dysplasia, and moderate dysplasia. Type 5A indicative of carcinoma in situ. Type 5B is squamous cell carcinoma, and then invasive. So tricks of NBI is one has to take his scope or a bronchoscope as close to the lesion. So now we are designing a soft hood over the bronchoscope so that I can touch the lesion, and then with the still images of that particular region, we can focus it and do the assessment of that particular lesion. And that helps in our deciding about the target biopsies. So many times we see the patient is having a full-fledged growth and the biopsy was taken from the wrong side. So target biopsy can be done with using this technology in an office setting. So our region of interest is width of the microvessel, continuity and architecture of the vessel. So if you look at here, the tricks of NBI, we have taken the picture from very distant distance from the lesion, then we've gone closer to the lesion and gone as close to the lesion. So, but now the Olympus has come up with a 170 this is scope with a no zoom function. Now with the ENF system, we can zoom the image also. But still, I think that like in gastroscopy, there is a soft hood which is attached with the gastroscope. You can take the image and attach your gastroscope to the lesion and then take a image from that lesion and analyze that lesion accordingly. So for a post-radiated patient also, you can assess it using this technology for knowing the recurrence or the residual disease. So that is how carcinoma situ looks like. That is fine dots, well defined, and intramucosal will give if you look at this picture, you will see there is a three-dimensional, there is a few capillaries which are more of cyan color. So these are the submucosal and these are the mucosal capillaries. So dilatation, meandering of the capillaries, caliber change, non-uniformity in each intrapapillary capillary loops. So like this buccal lesion, if it look like an inflammatory lesion, gone very close to it on white light, now it has created suspicion, and it was a submucosal disease, mucosal and submucosal disease. So type 2 pattern is an inflammatory lesion, which is where there is a arborescent capillaries which is coming up from the transversely and covering the vocal fold. This is a chronic laryngitis patient. So how the transition starts when the patient starts smoking it and capillary changes start appearing it. So type 3, if you look at it, there is an umbrella type of lesion and there is a transfer capillary which is coming up. And still we can appreciate there is a capillary structure which is underneath this white dysplastic changes there. So it is very difficult to differentiate whether it's a hyperplasia or dysplasia. That is only by the pathologist has to assess it. So this was an operated case of right vocal fold malignancy. The patient came with again hoarseness of voice. We looked at again on NBI, and this lesion has shown a very close to that, show the white dots like this, and it is suggestive of moderate dysplasia. This is another lesion having a white dysplastic lesion, but if you look at the just adjacent to the white lesion, there are few changes which are indicative of that. So type 4 pattern is like this. Type 5A, as I've told you that, but sometimes you see the mixture of pattern. There is a type 5A, there is a big growth also is there. So from where you are taking the biopsy, that will decide on the future course of action, because the limit of dissection you have to decide it. Type 5B, as I said, it is earthworm or a tadpole-like structure branching. Type 5B again. So these are the various pictures you have to take it as close to the lesion. So on transoral approach, when we are excising the tumor, the NBI has got a good upper hand. Once you are assessing a tumor, at the time of surgery, you can define the margin of the tumor, and then you can do the dissection accordingly. The depth of dissection, you cannot decide it on with the That is only by the palpation and with the high definition microscopic images, what you are using a good microscope, then only you can decide about the depth of the field of the cut of with the laser, and with the highest magnification you have to use with the microscope. So up staging of tumor, you can do it per operative. You can see it. And this was my very early article on up staging of tumor in pre-malignant early glottic lesions. Now my series has gone up to 160 cases. So I'll be coming up with a newer, the histopathological correlation with NBI, pre-operative, per-operative, and post-surgery histopathological correlation. So what are the limitations of NBI? There may be false positive and false negative cases with NBI. Difficulties after dissection of tumor because it has no, it cannot tell about the depth of invasion. The learning curve is there. In post-radiated cases, stagnant saliva or sticky mucosa sometimes gives a false image, and reflection also, it's a difficult to interpret in post, and especially in cases of base of tongue cancers. So limitation, if there's some mucosal growth, underlying growth, it is difficult to interpret the type of pattern you see it. Target biopsy, I've already indicated that how to take a target biopsy in unknown primary, very early lesions. I have detected at least 5-6 cases in a year. I usually detect it without getting the patient for PET scan. So now it has come up in a ELS guideline that NBI in all treated cases, laryngeal cancer cases, should be undergo a NBI examination to assess a early recurrence of the disease. Very high sensitivity, early detection, surveillance, upstaging and mapping already covered. You can rule out early other lesions which look like malignant. This is my book actually. And post-radiated cases are most difficult cases to assess. And these are few cases which look like malignant, but they are not malignant. They are tubercular lesions. Here in northern India, we get all such lesions, which gives a. And there are few articles which are coming up in artificial intelligence and NBI, and hopefully within 2 years' time, we will come up with AI, where interpretation can be done by a machine itself, looking at the pattern of capillaries, how the pattern look like, and then it can be classified into various categories. And there are two publications. One publication which has come up in manual versus automatic approaches using both the contact endoscopy with NBI, and you have analyzed almost more than 2,000 images into it. And single stage TLM is also a concept which has come up because of NBI, and now it has been reality that we don't go for a biopsy for early glottic cancer, where we have a mid-cord growth or a early malignant lesion where we don't do the biopsy, go ahead with the single stage TLM. Thank you very much. Hello.
Thank you, sir.
I think my time was up, so I stopped it.
Yeah, I think Vidya has a question. Before that, I'll ask one question to you, sir. So when you do resection, transoral laser excision above type 3 chordectomies, generally post-operatively, we see granulation formation, which usually stays there about 3 months' time. So if can we rely on narrowband imaging and avoid a second look operation based on the NBI in a post-operative setting?
Yes, definitely. Very easy to interpret, because most of the post-laser granuloma, they look like, if you go as close to it, they will not show that classical round dots, or only thing is you have to reassure the patient that your voice will improve. And in few cases, I think almost 2 cases, I have done the removal to improve the patient voice also. So most of these cases, granulomas, small granulomas, post-laser, I do the office base also for that matter. Right. So the patient voice immediately within 2 weeks time, it improves also. So right. That's the advantage of using this technology. and you have to reassure the patient. It's very easy to diagnose it that the reassurance is more important than assuring yourself, assuring to the patient that your voice will improve. Because he is scared of that mass. And if patient insists, you can start it with PPIs and alginate, other things, but usually they improve it. And few cases I have injected even hydrocortisone also. Sorry, Kenacort, not hydrocortisone.
Okay. Thank you, sir. Vidya, you can go ahead with the question. Vidya. Vidya had a question. I'll just read it for you. So Vidya tells, nice talk, sir. It was great to actually see the pictures of different types. His question is, what are your thoughts about other advanced imaging technologies other than NBI?
There are many there. Contact endoscopy is one. Raman spectroscopy is another one. But problem is the time is more with the other technologies.
So it's not practical. So NBI.
It is not practical, huh? It is just a 2-minute job with NBI. So I think in Indian setup where the limit is patient load is very high and interpretation plus the cost is very important.
Right.
Contact endoscopy takes beside the oral lesion, you can do it under local anesthesia for contact endoscopy. But for laryngeal lesion, you have to take patient for general anesthesia. And our all patients they are not insured patients, and that technology, that is why it has not picked up that. But and plus area is very limited using this contact endoscopy. So there are many advantage, disadvantage with that. But
yeah, thank you very much, sir. So can we have the next introductory slide, please? So moving on next, we have a talk by Professor Abhishek Mahajan, who is from Tata Memorial Hospital, Mumbai. He has done extensive research. He is a peer review committee member of DBT International EU India Horizon 2020 Challenge. He is recipient of the National AI Task Force grant for setting up Cancer Imaging Biobank AI Lab DPT 2021. He is an associate editor for Frontiers in Oncology, and he is a recipient of the Prize of India Award in 2020 and also fellowship from ANZHNS 2017 and many more accomplished. So welcome Professor Abhishek Mahajan to talk about artificial intelligence in thyroid.
Thank you, Akshay. Can I share my screen?
Yeah, please.
So in the next few minutes, I'll be showcasing our indigenously developed AI-based app at Tata Memorial Hospital with the team from IIT Bombay. That's the End Dimension Tech. They are incubator under IIT. This is an AI-based app for ultrasound stratification, which gives you all the scoring system across the world, whether you are in Korea, France, or in the EU or in the US, Asia TIRADS. So with this, I'll give you a brief background. There are many scoring systems. Some of them are qualitative and some of them are quantitative scoring system. The qualitative ones are the TIRADS, the French TIRADS, the BT and the ATA Society guidelines. And there are some quantitative scoring system where you actually get a quantitative score such as the Quacketal TIRADS, ACR TIRADS, and our scoring system, which we devised in Tata Memorial Hospital, which is called as the Thyroid Multimodal Risk Stratification Scoring System in the year 2016. So the scoring system which we proposed in 2016 and we published in JCO was the scoring system which had pointers to some specific key indicators on ultrasound, the negative factors which could predict the benign nature of the lesion, and also the pathological nodes. And based on this particular scoring system, we could actually come up with a score which could predict the risk for malignancy. So a score less than 3 was suggestive of a risk for malignancy of 2.4. Between 3.1 to 6, it was more than 18%, and more than 6, it was 80% risk of malignancy. Similarly, ATA also categorized patients into high risk, low risk, intermediate risk, and no risk. And we thought like it's very challenging for a radiologist or a clinician to sit and calculate these scores, and it becomes a very challenging process in the clinical practice to apply these scores and also give a proper follow-up indication to the patient. So we thought like, why not comprehensively develop an app which could, once you enter the scores, the features, you can get the actual scores. We also published the comparison of all these scoring systems, and also gave how these scoring systems are interrelated to each other and what is the probability into individual categories. So with this, I will just share the video of the app, how the app works. Just can you see the screen of the video?
Yeah.
So at the outset, I would like to thank the Fhno for giving us this opportunity to unveil this app. We are unveiling it today. You have to sign up for the app. It's a very simple system. You make your login ID profile with your mobile number. Once you've logged in, you can use this app personally. There's a disclaimer. You have to undergo check the disclaimer, and then the app tells you what all it can do. There's a home page over here, and then there's a back button over here. The first and foremost would be adding any new patient. So you can press on to the add new patient. Once you've pressed on to add new patient, you can enter the details of the patient ID, the patient age and gender. These are the mandatory fields you have to fill. Once you've done that, it will take you to the next step, which is how is the thyroid looking on imaging. So you will get this information. So if you press normal, the normal report of the thyroid would be generated automatically for this patient, and the system would tell you that the scores are 0. All the scoring systems have no probability of malignancy, and the patient can be sent home for and can be told that the thyroid is normal. However, if you select a new patient and you've entered the details, and after entering the details, if you select abnormal, then the system asks you whether there's a diffuse abnormality or a focal abnormality. So diffuse abnormalities you might see in thyroiditis cases. So I won't go into the detail of that, but if you've selected focal, then the system would ask you whether it is a multiple lesions or it's a single lesion. And then you have to enter the number of lesions, and this is an AI-based system, so it will automatically calculate whether you have added the right number of lesions or not. We will only give features of the most prominent nodule into each lobe. So let's see, now we've entered the total number of nodules of 5, and then you enter the number of nodules into each lobe, that is 2, 1, and 2. You go on to the next button, and then it asks you the features which you would like to enter. So here you enter the location of the nodule, and then you go on and enter the features. So first is echogenicity. These are the echogenicity factors, which is marked as markedly hypoechoic in this patient. And then you go on to the next, which would be the composition of the nodule. So all the features are shown over the top list. You can pick up the composition, even if you're not very accurate, you can match your composition with the given above. Then the system has an automated system of calculating the taller than wider or wider than taller. So you have to enter the measurements, that is transverse, anteroposterior, and craniocaudal. If you enter only transverse, then the nodule will become oval. And if you enter the next measurement, which the denominator is less than the numerator, the nodule will become wider than taller. If you have entered the denominator more than the numerator, it will automatically become taller than wider. Then comes the margins. You have to select one of the margins, and you can go on to the next. Once you've selected the margins, the system takes you to the next step, which is the echogenic foci, which can be microcalcifications, macrocalcifications, peripheral calcification, rim calcification, etc. Here we've selected microcalcifications, and move on to the next page, and that tells you whether there is vascularity in the lesion or not. So central vascularity, as we know, is the most commonly seen with the malignant lesions. So you can select one of the vascularity patterns that's selected over here is the central, and go on to the next. If you have done elasto in this particular patient, then you can also enter the elasto or the pathological nodes. So next section is the pathological nodes. If there are any pathological nodes, you can select absent or present. If they're present, go on to the next again, and that takes you to the elastography. So in the elastography, we are using this system which is proposed by the Asteria. Is a 4-grade system. Again, it is highlighted how the system is to be used for this particular any patient. And here we've selected a score of 3/4. And moving on to the next, some benign features, if they are seen, to be documented in the app. So such as spongiform nature, which is commonly seen with colloid nodules. And if you select this, as we're not selecting over here, it's a malignant nodule. And if you have any halo around the nodule, then you can also select the halo in this nodule. You move on to the next, and the score gives you a comprehensive report. You don't have to do anything. It tells you what all scoring systems are there, what are the risk factors, and the score as per that particular scoring system. And the clinician or the phonologist can advise you for the management of this patient. Similarly, this system will prompt you to enter one prominent nodule in each of the lobe if you enter more than that, and it will also give you at the end a comprehensive checklist whether you have done the right thing for the patient. This is again from our published work. So this scoring system is jointly developed with N-Dimension team from IIT Bombay. Apart from this, you have other things. You can search your patient, you can do your internal audits, you can do your sensitivity, specificity, accuracy check and audits of your data entered. You can also check onto the relevant data which is published in the thyroid from our system. And this is a very safe app. We will be soon putting this app on the Google App Store and also on the iPhone store. It's a freely downloadable app. Initial 1 month will be for trial version. You can use this app and set it up to your convenience. And if any technical glitches, you can always get back to us. I'll just show. So I'll just take you through once again that the app has all these features. This is the most important feature that we have introduced, is the internal audit. You can, we will also provide you to enter whether the nodule turned out to be benign or malignant, and that will give you an internal accuracy and sensitivity specificity checkup at your own center or your own hospital. And the versions will be updated very soon. Relevant studies in relation to the thyroid will be also added. We are hoping that we will also add certain clinical risk stratification scores in this particular app, and even Bethesda will be introduced soon if we, in collaboration with our clinical and the pathological department, once the app has successfully worked on the radiology subsite. With that, I would like to thank my team at the Department of Radiodiagnosis and the Head Neck DMG at Tata Memorial Hospital. Without this wouldn't have been possible. Any questions? I'll be happy to take.
Thank you, Dr. Abhishek. It was a very, very ingenious and smart idea for a AI-based app, and especially thyroid ultrasound risk. I'll definitely log in and give it a try, the trial version. I did have a question, but I think towards the end of your PowerPoint, you did kind of answer it. I was wondering why we need to put the patient ID if it's a free base, but then you said for our own internal audit.
Yeah, so what we're trying to do is like, see, these scoring systems have come up with internal audits. They are not actually a sensitivity specificity audit scores. They are particular hospital audits where they show that this course had this much accuracy or risk of in malignancy. So you can actually do the adjustment as if you're getting more of microcalcification, did you get that many malignant cases or not? This will give you to do an internal audit. We will have an anonymized data collection at the end of the app, which will also help us, do the better deep learning of the app. Soon we will introduce an icon to upload a image of the related patient. And finally, the end result of this app would be that you don't have to do anything. You just have to upload the image. It will automatically pick up the features. So that will be the final product, which will soon be, like maybe in a year's time, we should be hoping next FHNO we might introduce that. I would sincerely thank the team at N-Dimension, because these guys are from IIT. They have had developed multiple applications with us. There's a pulmonary nodule detection app which works very well. So if anybody from the medical fraternity wants to get in touch with us, we do these apps free of cost, so we don't charge anybody.
Thank you so much. Thanks. It'll be actually a big help in the OP, because when sometimes patients, when they bring the ultrasound report, that doesn't have the thyroid score.
Yeah, so you can just enter in your own clinic. Yeah, you can do that. So I think the best benefited would be the clinician who's getting random reports, and then you can enter your Bethesda. So you can actually match whether the thyroids is matching with your Bethesda or not. So it will support the clinician a lot.
Decision making also. Thanks, Professor Abhishek.
Thank you.
So now we'll go ahead with the next speaker. Could we have the profile of Professor Dr. Sapna Nangia, please? Thank you so much. I'd like to introduce next speaker, Professor Dr. Sapna Nangia. She is a senior consultant in radiation oncology at the Apollo Proton Cancer Center in Chennai, and she's also she has a special interest in skull-based breast and gynec oncology. She is also the lead, the clinical lead in head and neck clinical disease management group at the Apollo Proton Cancer Center. She'll be talking about proton radiation therapy. Madam, the stage is yours.
Thank you very much, Vidyadan. It's nice to meet you again in the virtual world. With your permission, I'll just share my screen.
Sure. While you're sharing the screen, I also want to add a few more points which I got. She's also the visiting consultant in Indraprastha Apollo Hospital and also the editorial board in the Apollo Medicine, and formerly the chief radiation oncologist at Fortis Hospital, Noida, and also the advisor at Global Cancer Concern. So, ma'am, back to you.
Thank you. Thank you, Vidya. I'd like to thank the organizers of Fhno 2021 for allowing me the opportunity to share what is the first experience of proton therapy for head and neck cancers in the country. And this is as of December 2021. So a little bit about proton therapy. We know that proton therapy has a different physical characteristic. So this is a small cartoon. If the white is the tumor, and this is a photon beam, an X-ray, it traverses through the body and regularly at various intervals, gradually deposits its energy as it goes along. In comparison, a proton beam will travel and deposit its energy right at the pre-specified spot. And then, because this is a narrow band, subsequent smaller energies will be administered till the tumor has been covered by what is called the spread out Bragg peak, Bragg being the scientist who first described this. And what this leads to is the fact that we can spare the normal tissues that are distal to the tumor. By sparing the normal tissues that are distal to the tumor, it allows us to spare normal organs better. It may allow in certain situations dose escalation. And because the energy is being deposited in a very focused manner, there is a larger proportion of double-strand DNA breaks, which are more difficult to repair. So in this context, also the fact that this is now, we are on the third generation of proton therapy machines. The earlier proton therapies were cumbersome. They did not spare the tissues proximal to the tumor as well. But the third generation uses something called the pencil beam scanning technique, wherein basically you are using micro beams of protons to cover the tumor in a very conformal sort of manner. Am I audible and visible?
Yes, ma'am, you're audible and your slides are clear.
Great. So why do we need to discuss proton therapy for head and neck cancer? One is, of course, that we do know that head and neck tumors are in close proximity to multiple critical organs, which impact various domains, speech, mood. I mean, I don't really need to tell head and neck oncologists what the criticality of all the organs in the radiation area are. Suffice to say that acute as well as long-term toxicity and quality of life is an important issue. Besides that, we do know that since intensity modulated radiotherapy or the development of cisplatin, there really hasn't been anything that has improved either the outcome or the quality of life of patients of head and neck cancer. About a quarter of these patients are going to require retreatment. And therefore, we need to optimize the first treatment to make sure that we are able to deliver the retreatment, and also the fact that the retreatment has to be optimal. And then there is a special group of patients, the elderly, who are more at risk of the side effects of treatment and therefore may require modification of treatment, such as dose de-escalation, not giving concurrent systemic therapy, even though that we know is disadvantageous. We know that elderly patients who receive chemotherapy do better, notwithstanding what the MAC meta-analysis said, but now there is a lot more recent data suggesting that elderly patients who receive chemotherapy actually do better. On the other hand, young adults, where we want to reduce the low-dose pill, we know that the target that is encompassed by the 6 gray isodose is what where second cancers occur, and it's important for us to limit this. And then, of course, there are patients with comorbidities, wherein we wish to deliver what is optimal treatment and yet are compromised by side effects. So in that context, where is the role of proton therapy? I'm going to discuss that in 4 subheadings: sinonasal cancers, adenoid cystic cancers, cancers treated with radical intent, and oral cavity specific and oropharynx specifically with reference to mucositis. So just to briefly run through very little of the literature, we do know that the quality of life of patients, even receiving low dose, 60 to 66 gray, in a non-randomized comparison, we know that at various time points, different aspects of their quality of life are actually better in patients who receive proton therapy. And that actually disadvantage remains even at 1 year post-treatment, wherein there may be significant differences in head and neck pain and xerostomia, and very critically, in what is the role function of the patient. So as many as 98% of patients maintain their role function, vis-a-vis about 78, 79% of patients. This is in a very recent study by Sonam Sharma et al. And then this study by Manzar et al., which discusses the fact that, again, non-randomized, that 46 IMPT versus 259 VMAT patients, lower peg placement, lower hospitalization, a 22% reduction in end of treatment narcotic use, therefore signaling that there is less mucositis, reduced cough, reduced alteration of taste, etc. We also know in this comparison that is ongoing between patients undergoing IMPT and IMRT, when we look at the temporal trends of patients who have been able to resume work. So for patients undergoing IMRT, we find that there is no difference. Whatever the proportion of patients working was at the time when they entered the IMRT treatment protocol, it remained unchanged. However, in patients who underwent proton therapy, there was a significant difference, and a higher proportion of them were likely to go back to working, and there was less absenteeism and less composite work impairment in patients. This has been done using an instrument which measures the work outcomes after treatment. So in this background, at Apollo Proton Cancer Center, we started functioning in January 2019. We have treated 70 patients of head and neck cancer. And in addition, we have treated 20 patients with chordomas and chondrosarcomas of the base of skull. I am not going to discuss chordoma and chondrosarcoma patients. For paucity of time, I am restricting myself to the head and neck cancer patients, of which interestingly, because one tends to think, or this is the general impression that people have, that this is primarily for re-irradiation, but actually only 1/3 of our head and neck patients were treated underwent re-irradiation. The others were de novo. And of the entire group of 70 patients, the largest proportion was oral cavity tumors and nasopharyngeal and paranasal sinus tumors. I'll start just to make, because it's relevant to emphasize the role of proton therapy in chordomas. I'll start with the case report of this 36-year-old lady who had already undergone 2 surgeries, had undergone a gamma knife radiosurgery, and came to us with multiple cranial nerve palsies. And this is how horrible, if I may say so, her MRI was looking, with by compression of the brainstem from both sides, the cavernous sinuses involved bilaterally, explaining the multiple cranial nerve palsies that she had. And this is her post-surgery, excellent surgery, of course. And in the sagittal view, again, we see very relevant that the pressure on the brainstem had been relieved by the surgeon. But most importantly, this is her proton therapy plan, and I'm going to show you this in slightly greater detail. So we want to give a very high dose to the chordoma, which tolerates a dose of about 70 gray, given hypofractionated, not in 35 fractions, but in 32 fractions. And yet there is a very sharp dose fall off, and the brainstem surface, which is allowed 64, is getting 60. And then the brainstem itself only partially receiving 56 gray. So this underlines, and of the 20 patients whom we have treated so far, none of them have had a progression, and all of them have stable disease. Coming now to what I want to emphasize or discuss is the, non-chordoma chordosarcoma patients, starting with sinonasal cancer. Sinonasal cancers are, of course, difficult to treat, not just because of the proximity of the brainstem and the temporal lobe, and the optic nerves and optic chiasm, but also the eye itself is an organ at risk, the lacrimal gland, the cornea, the risk of glaucoma, the risk of radiation retinopathy, and which is why we know from literature that the outcomes of proton therapy are significantly better. There are multiple publications that tell us that there is a difference of almost about 15 to 20% in the disease-free survival, as well as the overall survival of patients in series treated with proton therapy. So, as I mentioned, it's a difficult cancer to treat, and this analysis of 335 patients treated not just with surgery, but a large proportion being treated with either radiation, 29%, or CTRT, 15%, surgery followed by adjuvant radiation, 20%, etc. It was very important that the volume of the disease be high in a center for results to be better. And the cutoff was 2 patients per year. 2 patients per year qualified at treatment centers treating high number of patients. We have so far treated 15 patients, of which 9 have had de novo cancers and 6 are re-irradiation patients. As expected, very diverse group of histopathologies, adenoid cystic, SMARC deficient sinonasal carcinoma, sinonasal teratocarcinoma, which I have to confess, these were the first time that we were treating any of these histologies. The others are well known, SNUC, alveolar rhabdomyo, etc. And as an example, I have this 31-year-old man. His cancer was detected when he lost vision in his right eye. And I'd like you to look at the target delineation or the kind of area that we had to address. So we were treating, of course, the bilateral maxillary sinuses, the facial nodes, the preauricular nodes, the intracranial extension. So here I'd like to emphasize the fact that proton therapy is not only for small targets, even in large targets, it's possible to spare the normal tissues in a better manner as compared to photon-based treatments, the best photon-based treatments. So this is his pre and post MRI, pre-treatment MRI showing this enhancement and the nodule that we see, enhancing nodule, as well as the meningeal enhancement that we see. Following 4 cycles of chemotherapy, 1 neoadjuvant, 2 concurrent cisplatin etoposide, and 1 post-treatment. This is the post-treatment changes that we see in the MRI. But what is most important to see is that this treatment was delivered in spite of a very aggressive regime with very minimal toxicity, as you can make out, the skin toxicity. There is pigmentation, but not much more than that. And the mucosal toxicity is negligible. And another important point to note, which is very precious, that we should preserve the left optic nerve and the optic chiasm. And these tolerated dose in the range of 54 to 56 gray, and we were able to keep it well within that range, while still ensuring that 98% of the target, the high dose target, received 98% of the prescribed dose. There is a lot of innovation that has gone into these treatments, and the one that I personally love is this, mouth bite that was made with a patient with very poor mouth opening. He had an alveolar inoperable upper alveolus lesion going on to the pterygoids with bad submucous fibrosis. And these are 2 Ryle's tube that we inserted into this dental material to make sure that he would keep breathing while the mouth bite was in place. Another mouth bite to push the tongue away treatment of a patient getting his third course of radiation in the right lateral position because he was unable to lie down supine, or pulling up the eyelid of a patient in whom the cornea has to be protected while we are treating a lacrimal gland lesion, adenoid cystic carcinoma. The scar encompassed the upper eyelid, and therefore, it was important for us to create this kind of a distance. So this is a gaze fixation. We are making the patient look in this direction to keep his cornea out of the way. And this is something, this is typically something that we needed to do in India, which is know how the titanium plate would interact with this is work that has not been done. After all, buccoalveolar cancers are an Indian problem. And this was done by our physics team on our request. And the results have actually been quite gratifying. So this is a gentleman with an orbital plasmacytoma with proptosis, as you can see, deviation of the eyeball. And this is him after the treatment, with, you can see, no keratitis. So this was his lesion. And this is he had undergone surgery for the frontal bone, and therefore it was a fairly large target which we had to treat. And yet we were able to do that quite successfully without treating the cornea. So this is where we stand for sinonasal cancers. We have treated, as I mentioned, 15 patients, of which 14 remain disease-free. One patient has had progressive disease. He was metastatic to begin with, and he has had progressive disease, but the others are doing well at an average follow-up of about 10 months. The next lot of patients in whom proton therapy has a major role is adenoid cystic carcinomas. And we have recently, one of our case series of 6 patients has been accepted for publication. So these are lesions that are typically, involve the base of skull, inoperable. These were all base of skull lesions. And however, for adenoid cystic carcinoma patients in general, proton therapy has very good outcomes. And in fact, a recent study has even raised a question mark as to whether, it's important to put patients through surgery at all. I mean, of course, I'm not talking about salivary gland lesions, but more base of skull lesions. Where survivals and overall survivals are in the range of about 90% or so. Disease-free survival as well as overall survival. So these are some of our patients before and after pictures. As you can see here, very dramatic reduction in the tumor or this pressure on the brainstem and then relieved. Of these patients, we have treated 10 adenoid cystic carcinoma patients so far. And one has had a recurrence, the same sinonasal that I mentioned, and the other patients are so far doing well. This includes an equal number of re-irradiation and de novo patients. So coming to our outcomes of treating patients with radical intent, we have treated 43 patients so far, 18 de novo, radical intent, and 25 adjuvant. Concurrent chemotherapy has been cisplatin in 14 patients, nimotuzumab in 2 patients, and 3 have had aggressive combinations because of their histology, such as alveolar rhabdomyosarcoma or sinonasal teratocarcinosarcoma. 90% of these patients are alive at a median survival of 13 months. And the 1-year disease-free survival is 85%. We do have 2 patients alive with disease. It is important to note that about 35% of these patients were above 65, and about 53 or 54 were locoregionally advanced or inoperable. This actually becomes important when we see it in the context of the fact, I can't seem to go back. Yeah, it becomes important in the context that we see that the average treatment break duration has been 1.2 days. None of the patients have had prolongation of the overall treatment time. In fact, we have been able to escalate the treatment in the latter half in a significant number of patients. The other important thing to note is that the average NGT duration, and in all but 1 patient, the NGT duration is reactive rather than at the outset, has been 19 days. And if we look at the literature, the average duration of insertion of an reactive NGT is approximately 100 days. So this is where there is a difference. And why there is a difference is something that I will come to now. And that is, I think, what I believe the difference is happening primarily because of the difference in the dose being received by the mucosa. So this is looking at only the oral mucosa, and this represents a difference between the proton plan and a photon, a good quality, treatment quality helical tomotherapy plan. And we see that there is a 10 to 25% reduction in the dose that is received by the oral mucosa. And I think this is really the reason why the outcome of the proton therapy patients is what it is. Again, this is the difference between helical tomotherapy, average doses, the dose received, the average dose, the volume receiving various dose points, 32, 39, 45, which have been identified as important in literature. And as you can see, the difference is really marked for the oral mucosa that lies outside the target, where the difference may range from anywhere between 51% difference and a 60% difference in the reduction in the dose that is being received in proton therapy. And this, I believe, is really the, the crux, or how or where we are going to see a change in certain groups of patients, such as the elderly or those with comorbidities. Now, this is using something that we call normal tissue complication probability. So this is a radiobiological principle. There are certain formulas, models. Then the models are first created and then validated. And we have used a validated model to compare for a group of 22 patients consecutive of oropharyngeal and oral cavity tumors. This data was for those patients, these consecutive 22 oral cavity and oropharyngeal patients. And this is their normal tissue complication probability. And we can see a significant difference in the, difference in the probability of developing, which ranges from about 25 to 28. In ipsilateral, for example, it is about 25 versus 42%. Even in bilateral cancers, there is a significant difference, 25 versus 40%, the risk, the normal tissue complication probability pertaining to mucositis. So this is achieved without any compromise in the prescription of, the coverage of the target, the high dose target and the low dose target, without compromising any of this. This is the clinical picture of patients. Some of the patients, two of these patients are ladies in their 70s and who have received, who've received post-operative radiation for carcinoma of the tongue with minimal mucositis. Similarly, the superior frames, we see patients. This is a gentleman who was receiving radiation for tongue, the cheek on this side, as well as the palate, and yet the mucosa on the contralateral side is spared very beautifully. This is a gentleman with adenoid cystic carcinoma of the right maxilla region, and the contralateral mucosa and even the soft palate on the contralateral side is spared of any mucositis. So in this context, a couple of patients, if I have the time, Dr. Vidyadharan, do I have the time for another 2-3 minutes?
Sure, ma'am. We've run past the time, but please go ahead. 2 or 3 minutes is fine. Thanks.
Okay. So this is a 38-year-old gentleman. He was treated, so I'll just go through the before and after pictures. This is December 2019. And this is, then he had neoadjuvant chemotherapy followed by proton therapy. And this is about 18 months post-treatment. Very happy to see him go back. This was a really advanced palatal lesion going on to the pterygomaxillary fissure. And, we had very guarded prognosis. But after this, I think we are a little more, aggressive and prognosticating and also in treating. Another patient, a 40-year-old lady, adenoid cystic carcinoma, with encasement of the optic nerve, detected in December 2019. She came to us. It was actually also in close proximity to the other optic nerve. And so she was treated again quite aggressively, 70 gray 35 fractions, and still managed to spare the contralateral optic nerve and the optic chiasm. She was treated with current cisplatin. And this was her visual field analysis before treatment, which means that she wasn't really able to do the visual field analysis. And this is her latest visual field analysis. Even though we have taken high-risk consent for a loss of vision because it is encased by the tumor, the lesion was encased by the tumor, and we did not respect the tolerance of the nerve on this side, but it's gratifying to see the outcome. So hypopharyngeal cancers, again, we don't normally, the reasoning was that no, it is not something where proton therapy has an impact, but we have seen that there is a significant reduction in the dose to the oral mucosa as well as the midline mucosa, which translates into advantages of uninterrupted treatment, less weight loss, and less nasogastric tube insertion. This is the team, the head neck team at the Apollo Proton Cancer Center, and it's indeed a privilege to work with them. And this is the radiation team, and the youngsters here put in a lot of hard work, the physics team and the medical team, our team of technologists. And of course, the entire head and neck department includes a lot more than just the doctors. Thank you very much for your attention.
Thank you, Dr. Sapna, madam. Thank you for your talk and for sharing your experience. Proton therapy is slowly establishing itself as an effective treatment modality for complicated head and neck tumors, while minimizing radiation dose to vital structures such as eyes, mouth, and brain, so thereby preserving vision and smell and swallowing function. Thank you so much, ma'am. We almost reached to, we have passed our time. So I would, there are no questions in the chat box, so I would just say my thanks and we move on to the next session. So I would like to thank our esteemed experts for their talks. And I would also like to thank the Fhno organizing team for giving us the opportunity to showcase such technologies, which I feel will be commonly used adjuncts in the head and neck cancer treatment. So thank you so much, and thank you, everybody.
Thank you.
And back to the organizers. Ms. Shalu, you can, I think, should show to the next hall. Thank you.
Okay.
Good afternoon, Dr. Mura.
Hello.
Dr. Amura, your session is in Hall A, sir.
Sorry?
You have to log on and go to Hall A for your session.
Already?
Sudhir Bahadur State of Science Symposium.
Okay. So can I get the URL? I have only Hall C.
Okay. I'll just send the URL in the chat here. Okay, sir.
Okay.